administrative guidance. Other than the consultant, there are senior house officers, registrars, senior registrars are also available depending on the type of the hospital. So important thing, and because you are not alone in this ward, so you don't need to know everything when you come to do your medical appointment or any other appointment, because there are seniors always. You should get their guidance and assistance every time. And so when you come to the ward, you will be given general guidance and dress code. The SLMC has given a dress code. You can go to that website and see what's the dress code that they had given. They want you all to wear the shirt, the shirt, trouser, tie, and the shoes. And the ladies' sari or either skirt and blouse. But after the COVID, the era, most of the doctors are wearing scrub suits, including myself. So attitude and behavior, you should be very kind and courteous to all the patients, irrespective of their behavior. The intern should keep the patient and the relations informed about their illness. But if you don't know anything, if you're not sure, you can tell always, I will ask from my seniors and let you know. It's very important. And every day you have to do the ward rounds. And I cannot tell you at what time that you should start your ward rounds. But anyhow, you have to complete your ward rounds before the consultants come to the ward. Make sure that all the investigations that you order are carried out and arranged and available as well. So all acutely ill patients should be given priority and must also be examined in the afternoon as well as in the night, maybe more frequently as well, depending on the severity of the illness. And you should know about your patient very well, everything about your patient. And you need to document all the informations with the time and the date, and you should sign, or you have to write your name as well. And you should promptly attend to a patient when requested by the ward staff, usually by the nurses. And under no circumstances should prescribe treatment over the phone, even if somebody requests to do so. Every patient must be seen in person before prescribing treatment or advising on management. This is very, very important. And the condition of seriously ill patients should be regularly monitored and keep the senior colleagues informed. This is again very important. You should not hesitate to summon the SHO, registrar, senior registrar, or consultant at any time of the day or night if the necessity arises. Remember this. Most important person in the ward is the patient, not your consultant. You are required to clerk all new admissions. All patients admitted to the ward should be seen within minimum delay. Maybe that patients who are admitted in the morning, you should clerk them by 12, and in after 2, but before 4 o'clock, like that. So, but there are certain patients that you need to see immediately. These are the stamped admissions. Stamped in the sense their rubber stamp is done, saying that the should be HO to see immediately. That's why it's named as stamped. So you, after clerking the patients, you have to give your provisional diagnosis, and after the history and the examination. And you need to arrange the relative necessary investigations as well. And it's important to record all the clinical notes. That's your bed ticket, the date, time, as I said earlier. When you, at each and every time that you see the patient, this is very important. And all entries should be neat, legible, and should be written in ink. And every sheet of the clinical note should bear the name, reference number of the PhD number, and also the ward number as well. Make sure all these things are there when you make your notes. All reports of investigation should be seen by the intern house officer, and you should sign it and should be entered into the notes in a chronological order. All the procedures, transfusions, and instructions given by the senior should be recorded with the time, date, and the time in the clinical notes. Because your documentation is very, very important. The final diagnosis should be entered in the admission sheet in block capitals in the space provided. The intern should make sure that you should write the diagnosis card when the patient is discharged from the ward, because unless you put your diagnosis card, write your diagnosis in the BHT, and the nurses cannot send these records into the record room. So you have to make sure that you write your diagnosis when you discharge the patient. So what about the ward procedures and other procedures? So you need to get the consent for all the procedures. Remember this. Give a priority for urgent procedures such as blood cultures and other cultures and also lumbar punctures. And arrange in special investigations such as aperture endoscopy to echocardiogram. Or for all these things, you need to get the patient's consent as well. So prepare the patient according to the procedure and discuss with the relevant team as well. Otherwise, you will send the patient at 8 o'clock, and the patient waiting period may be more 3 or 4 hours. Not only the patient, as the staff as well. So avoid that, communicate with the relevant team and get a date and time, and send the patient and at the appointment that they had given. So I'm not going to discuss anything in detail about the prescribing and de-prescribing because there's a lecture on this. But this is very important thing every day, that you have to look at the drug chart and see whether the drugs that you prescribe are written properly in the drug chart, and the doses, the frequency, and the duration as well. Not only the prescribing, you have to make sure then when the drugs that any medication is not required to be prescribed as well. All the medication should be written in the generic name. And the investigations, they should be requested on rational basis. Don't do unnecessary investigations. For example, patient who has admitted with a leg pain, you don't need to ask for an QLE DCG. A short clinical history should be entered in the space provided in the request form. The investigations form must be completed in full, the name of the patient, BHD, and the ward number as well. There are certain different investigations that you send to the different departments: lab investigation, radiological investigations, X-rays, and the other scan, CT, and the MRI. For certain investigations, you need to get a time and the preparation as well. So you can learn these things during your appointment. And all the house officers should know how to take an ECG. The referrals should be from one consultant to another consultant. Remember, you can't put your signature into a referral. So writing a referral is duty of the consultant, but most of the time that the consultant do ask you all to write the referral and they sign. But make sure that you write it properly and with the legible handwriting, again the date and time. If it is urgent, you have to make sure that it's right as urgent referral. And this is very important, the communication. Very good communication should be there with the patients, your peers, the other staff, relatives of the patients, and when you communicate over the phone as well. So discharges is again very important. The patient's condition before discharge and the date and the time of the discharge should be entered in the clinical notes clearly. You cannot just write discharge. You have to write the patient information and everything. Then only you can say that patient is fit to go and wants to go and discharge. Those things actually will be, the guidance will be given by the seniors. You can't discharge on your own. Remember that. Whenever possible, adequate notice should be given to the patient regarding the discharge, because they can make the arrangement for the discharge as well. So give a good diagnosis card, including relevant information. And you must give a diagnosis card for all the patients, including the patients who left against medical advice. Remember that. Do not delay in writing the diagnosis card. Otherwise, patients and the relatives, they have to wait to go home until that to write your diagnosis card. You have to always prioritize for this, and you can plan your discharge early. If you know that your patient is going home tomorrow, that you can plan your discharge today itself. You can write the diagnosis card and everything, and keeping the final summary or follow-up summary or whatever summary given by the consultant as the last thing. When you're transferring a patient from one hospital to another, there's a separate form that you have to fill it properly, and you have to write why you transfer the patient, a short history and the possible diagnosis, and the reason for transfer, and also available investigations, and the treatment also should be written. Why I say this, sometimes the transfers that we get, we are missing most of the investigations and some of the management as well. If you are given some antibiotics, you need to write the duration as well. A letter of consent should be obtained prior to transfer where relevant. For example, if you are sending for upper-GI endoscopy, before transferring, get the patient's consent. And all transfers must be recommended by the consultant and authorized by the head of the institution. So death. You need to confirm death. And once you confirm the death, that is, you need to immediately inform the relatives as well. This is done by phone, and you should inform, because if there are contact numbers, you can contact the relatives and inform. If not, you have to inform the office to inform the relatives about this death. Discuss with the seniors about the cause of death, and you can give the death declaration actually, and where relevant in most of the patients that you can give the cause of death. If you can give the cause of death only, that you can give the death declaration form. You can fill the death declaration form. And in certain situation, you need to, when you don't know the cause of death, that and also certain situations like in poisons, the road traffic accidents, such as in those situations, and the patients who are in the prison, and these kind of patients need anyway inquest after their death, whatever the cause is for the death, and you need to follow the specific guidelines for that. And if you know the cause of death, you can give the probable cause of death, but you cannot fill the death declaration form. Remember that. So if you don't know the diagnosis, if you want to know the diagnosis, you can ask for a pathological postmortem, which will be done by the pathologist. And usually when the chronic illnesses, after doing so many investigations, and the illness is a mystery, something like that. In the situation like that, we request for a pathological postmortem. And you need to arrange the necessary paperwork without delay, such as the declaration form and the requestion in inquest. So you have to give priority for a death, definitely, because let the relatives to give their last respect to the deceased. So this is very important. So ward reviews or follow-up. So you need to arrange a follow-up where necessary. The patient who do not need follow-up will be reviewed in the ward accordingly. For example, if you are sending a dengue patient, if you want to see a full blood platelet count, again, sometimes you might ask the patient to come to the ward or to a closest hospital. But you have to give an appointment. Don't ask them to come at 8 o'clock because at that time you are doing the ward rounds. So give them a convenient time. If you are given an appointment at a convenient time, you must see them at that time. Remember that as well. So always, you come to the last few slides. Be punctual and act professionally. Be honest. Always tell the truth. You don't have to make sure that your diagnosis is correct, that you have done everything perfect. Not necessarily. But we can understand you very well. Important thing, be honest and tell the truth. So care your patients with humility and empathy. Never shout at patients. Even they shout at you. Give your opinion in patient management. Don't hesitate. You are an important member of the team. And the burnout and compassionate fatigue. So this is very important because most house officers are working, and sometimes they don't get a break as well. This is not good. And take breaks and drink plenty of fluids as well. Have a good meal before you start work. Very important. So don't think that we are machines and we don't want you all to behave like that. You are also human beings, so you need to get some breaks as well as a good meal as well. Last but not least, you should never tolerate harassment of any form, physical, psychological, sexual, by anyone, senior colleagues, other staff, or strangers. There is always someone who you can speak to, and you must do so. Remember that. Never ever bully or harass others as well, your senior colleagues or other staff or your other peers. Good luck. And you have chosen the most rewarding profession, which gives a very good personal satisfaction. I always think like that. And your dedication and commitment is very important to be a good doctor. And remember that house officers, the interns are the most wanted doctor in the ward. So these are the references, SLMC guidelines for the internship, medical and certificates. There's again the website. You go to the website, and Sri Lanka College of Intern Medicine very soon will release intern survival guidelines. Maybe in next month. So I must thank again the Dr. Tushara Matthias and the Sri Lanka College of Intern Medicine for arranging this program together with the Ministry of Health. Especially must thank Dr. Roshan Fernando for organizing this wonderful program. So all the best pre-intern colleagues. Wish you good luck and hope that you will enjoy your internship. Thank you very much.
Thank you very much, Madam, for that introduction to internship. That was Dr. Kumudini Jasinga, President of College of Internal Medicine, giving the insight of expectations for interns. Right. So thank you once again, Madam, for collaborating with Ministry of Health and organizing this serious lecture series for interns. So next up is another interesting lecture by Dr. Madhuwanti Hettiarachchi, consultant physician, on poisoning and what to do. I think Madam has logged in. Over to you, Madam.
Good morning. Can I share my screen?
Yes, Madam. Can.
Good morning, everybody. So this is the first lecture for the day. This is actually a very important topic. You know, you'll encounter these patients every day, poisoning. So without further ado, let's start with the case scenario. There's a 45-year-old farmer who has admitted to a unit, and you're the medical officer in the ward, and he's found unconscious in the paddy field, which has occurred about 1 hour earlier. Now he's on treatment for a psychiatric illness, but the relatives are not aware about the medications the patient is taking. All right, now how are you going to assist this patient? You have to do the ABCD approach, as you are aware. Now in this patient, let's have a quick look at what's the airway. So airway is actually not patent. There are a lot of secretion, and when you have checked the saturation, it is 91% on room air. The respiratory rate is about 10 per minute, and there are a lot of crepitations and wheezing you can hear in the lungs. And the pulse is about 50, blood pressure is 80/60. And as you are aware, the GCS is very low. It's around 5, and there are no convulsions, but you can see the pupils are very small, about 1 millimeter in size bilaterally. CB is fairly okay, 150 milligrams per deciliter. He's sweating profusely, and other cranial nerve examinations is difficult to elicit. There are no obvious bite marks. Again, it is very essential to look for these. Now, after assessing the ABCDE, now what is the most likely diagnosis? Now, it can be either toxicology cause as well as a non-toxicology cause. Now, this patient needs to, look for these other non-toxicological causes as well, because the patient was found unconscious. So the pontine hemorrhage, is it possible? Yes, it is. Lithium overdose, some of the clinical features you can explain by the lithium overdose. What about the organophosphate ingestion? What about crate bite? Can it be post-ictal stage of epilepsy? So all these differential diagnoses, of course, actually may be right in one way or another, but you have to exclude one by one. Now, pontine hemorrhage, you can explain the small pupils and the depressed respiration, but the other things you might not be able to fit in everything. Again, the lithium overdose, you can explain the bradycardia and hypotension. Because the patient was having a psychiatric illness, we had to take this diagnosis also. It can be any other antidepressant medication also. So you have to think about that as well. And then organophosphate ingestion. Actually, the organophosphate ingestion, you can explain all the things the patient is having. Small pupils, the patient was bradycardic, hypertensive, crackles and wheezes in the lungs, and the lung respiration also be depressed, and there's excessive sweating. The crate bite also, you can explain the respiratory depression, but not all the things the patient is having. Post-ictal stage of epilepsy, then again the patient might have had some aspiration features. Most of the other things you cannot explain by the epilepsy alone, but all these things will come as differential diagnosis, but you have to see what diagnosis fits in. Now, I'm not going to go into the details of doxydromes today, but if you know, this actually a cholinergic crisis, the organophosphate ingestion. So it's all the features suggestive of cholinergic crisis is there in this patient. So your diagnosis would be organophosphate ingestion. So what are you going to do as a next step in the immediate management? Now, you have diagnosed cholinergic crisis, and the patient might be having organophosphate, poisoning. So what is the next step in the immediate management? So let's see your responses. I hope you can sort of, answer yourself and see. So are you going to induce vomiting? Never in any toxicology patient. Induction of vomiting is you ask the patient to, drink something and ask the patient to vomit. So that should never be done. So most of you all think the induction of vomiting is synonymous with the gastric lavage. Please remember that it is not. Okay. So it is actually contraindicated. Gastric lavage in this patient may be important, but again, the patient is actually having a GCS of 5. So you might have to intubate the patient, and you might have to consider the antidote also before attempting the gastric lavage. Activated charcoal, again important, but can be given after antidote and after intubation and the gastric lavage. Here, the correct answer is the atropine. Why? It's the antidote, and the patient is having very low GCS with low blood pressure and the pulse rate. By giving atropine itself, you'll be increasing the pulse rate, you'll be increasing the blood pressure, and the lung secretions will be dried out. So that is why you should give the atropine as the first measures. Whenever the patient comes, you put a 2 sets of cannulae, and then while resuscitating, you have to start atropine in this particular patient before even attempting to intubate, because if you try to intubate at that point without atropine, you might increase a vasovagal attack, because the pulse rate is anyway reduced with lot of secretions. You might be not be able to see the airway properly, so it will be a difficult intubation. So start atropine, then at the same time it should be a concomitant process with all of the people coming in and helping you. There should be a team. One is trying to intubate the patient, getting the things ready, and one is putting the cannula, one is administering an atropine, and all the things should go hand in hand. PAM, of course, it's an antidote. Again, you have to consider maybe after atropine. All right. So I'll talk about it little later. So what are the indications to start atropine? As you're aware, now there's a blood pressure, systolic blood pressure less than 80, pulse rate less than 80. There are viscous and crackers, small pupils, and excessive sweating. So these are indications to start atropine. If you're thinking about organophosphate poisoning, of course, you don't have to fulfill all the things, but if at least, if one or two are there, you have to start the patient on atropine anyway. And how are we going to elicit atropinization? Now we will start atropine. Once the patient has achieved the atropinization status, you might have to reduce the atropine. So how are we going to see whether the patient is atropinized? So if the patient is having a clear chest, heart rate more than 80, pupils no longer pinpoint, dry axillae, and systolic blood pressure more than 80 millimeters of mercury. Now pupils will take a little longer time to dilate. So you have to consider if it is no longer pinpoint that the patient has achieved atropinization. So actually you can go by the chest, clear chest, and the heart rate. So those two are more than enough for you to elicit the atropinization. Now, how are you going to give atropine? Now, initially, you have to see whether you are going to 3 or 5 vials. It has to be a bolus. If the patient is not having many clinical features, you may start with the lower dose, like 3 vials. 1 vial is 0.6, and you can go up to 5 vials as a bolus, and you have to double the boluses, double the dose every 5 minutes until the patient is fully atropinized. You check 5 minutes whether the patient has achieved atropinization. If not, you double the dose. Now, if we started with 4 vials, then double it, 8 vials. The next 5 minutes, 16 vials, something like that. Okay. So once the atropinization is achieved, do not stop atropine. You have to calculate what was given as boluses before. Say if you have given 300 milligram as boluses, okay, because 1 vial contain 0.6, you might have to give, so many boluses. So if you given 300, you need to start an infusion using 1/5 of what was given as boluses. So 1/5 of 300 milligram is 60 milligram. So you start with a 60 milligram infusion per hour. All right. Now then you keep reducing the rate every half an hour, depending on 3 vital parameters. Look at the lungs, heart rate, and the blood pressure. So look at those things and try to reduce the rate every half an hour. All right. Now, and then you repeat the parameters at 30 minutes for 3 hours, hourly for 6 hours, and 3 to 6 hourly for next 24 to 48 hours. So review the parameters: 30, hourly, and 3 to 6 hourly. If atropinization is lost at any point, you need to give boluses, top-ups, until they disappear again. Now, the patient is on going on 60 milligram power infusion, and then all of a sudden, you see that the patient is getting a lot of crepitations in the lungs. Then you add, you have to give another set of boluses to make the features disappear. All right. So for an instance, you had to give another 100 milligrams. So from that 100 milligram boluses, you get another 20%, that is 20 milligram. And then you add to the existing infusion of 60 milligram per hour, and then you run 80 milligram per hour infusion, then onwards. I think I hope that I have made myself clear to you all. So that is how you calculate the infusion. So do not stop the atropine infusion, suddenly at any point. You have to tail it off, discussing with the seniors and the consultant opinion. So you might have to continue it for at least 2 to 3 days sometimes. Okay, of course, because the some of the lipid absorption OPs, I will come to that little later. So it will be in your body for a long time. All right. Lipid absorption happens in certain organophosphates, lipid soluble organophosphates such as profenofos. I will talk about it later. So all these things will cause more effects on more days. So you have to be continuing the atropine for a longer time. So if the patient develops dry mouth, mydriasis, blurred vision, and hot dry skin and tachycardia, those may be the features of atropine toxicity. So you have to look for those things as well. So they will have, very warm skin, very dry skin, very reddish skin, and they will be hallucinating, and picking up things in there. So these are the effects of atropine toxicity. So you have to be little careful about that also. So while this is happening, you need to intubate this patient, put NG, arrange gastric lavage, and give activated charcoal. Remember, if the GCS is less than 10, do not start lavage in that particular patient. You have to protect the airway first. Put an NG again after protecting the airway, and then do the lavage if the indications are right. Okay. So in a toxicology patient, it's always better to put, intubate the patient. If the patient is drowsy, they can't maintain the airway, they will have risk of aspiration. So better to protect the airways. Sometimes, after about 48 hours, you can take the tube off safely. So don't take much time. Don't wait until the GCS goes down to about 8 to intubate a toxicology patient. So what is the place for PAM? Okay, so you will ask me that question also. So atropine will only help with the muscarinic effects and does not bind to the nicotinic receptors. So it is usually ineffective in treating the neuromuscular dysfunction. There can be muscle weakness, tremor, and fasciculation. So at the moment, we are actually not giving PAM for OP poisoning because there are not much of proven effects, not much of studies showing that a PAM has a very good effect. So at the moment, we are not giving the PAM, but it is recommended for the nicotinic effects, but you have to give it within 48 hours of poisoning also. There's no point giving it after that. And PAM has to be given 2 gram IV over 30 minutes and may repeat after 30 minutes, or give continuous infusion if severe. Continuous infusion is at a rate of 8 milligram per kg per hour in adults. Okay. Again, I have told you atropine must be given before PAM to avoid worsening of muscarinic mediated symptoms. It can happen due to transient oxime-induced acetylcholinesterase inhibition. So that is why you need to give atropine before you give the PAM. Otherwise, there will be worsening of muscarinic mediated symptoms also. Now, there's an entity called intermediate syndrome. I hope you know that in organophosphate poisoning. It usually occurs between day 2 to 4. There will be neck and proximal limb muscle weakness, and they die from respiratory paralysis. So the treatment is intubation and ventilation at that point. So if the patient is already ventilated, make sure that you wait for 2 to 4 days, because otherwise what will happen is you will extubate the patient, and then again in day 3, the patient might go into intermediate syndrome. Remember that also. So how are you going to check whether the patient is going to intermediate syndrome? You check the proximal limbs. Sometimes the patient can get up from the bed by using the proximal muscles of the arms and other proximal limbs also, using that. But better to check it by asking the patient to get up from the bed while you are pushing the forehead into the bed. Now you'll be pushing the forehead and not allowing him to get up, and then ask the patient to get up against your resistance. So that's the best way. So then you will see how the neck muscles are weak. Sometimes they use the upper limb, upper trunk muscles for them to get help, and they can get up sometimes with the help of those. So to prevent that, you can do that, and then ask the patient to do a full 1 breath count and see whether the patient is having, and at least they should be able to count 20 to 30. Now if they can't do that, the patient is having weak respiratory muscles also. So the intubation is and ventilation is the treatment for this patient. Now I told you about these lipid soluble organophosphates. They get absorbed into the fat. So malathion, profenofos, diclofenthion, fenthion. Though these are trade name is actually the profenofos. The most available lipid soluble organophosphate in the market is that. So if the patient has taken that, make sure it's so toxic, and you have to the actions will be longer. So you have to might have to give atropine for a long time, and sometimes the intermediate syndrome also comes a little late, not the usual 2 to 4 days. It get rapidly absorbed into the fat, and then there will be delayed redistribution from the fat stores. So up to 5 days, you might have to expect the symptoms, and prolonged illness may be going up to about 30 days. Now, whenever you see a patient with toxicology, this is how you manage. Assessment and management of a toxicology patient is by RESUS RSI dead pathway. So RESUS is for resuscitation, R risk assessment, S for supportive care, I for investigation, D for decontamination, E for enhanced elimination, and A for antidote, and D for disposition. But this doesn't mean that you have to go according to this order every time. Now, I said sometimes antidote has to be given even at the first stages of the management. All right. So that depends on the particular patient and the clinical condition the patient is having. Now, remember, there are important things for you to note whenever there's a patient comes with a poisoning. Now, the patient might not be able to tell you this whole story. So ask from the patient when they saw the patient last to guess the timing, because its timing is very important to arrange the gastric lavage, to give the activated charcoal. The timing is very important. Okay, so ask for any remaining tablet which was lying around the patient, any poisons, any blister packs, remaining poisons with bottles. Ask for any clinic notes from patient or relatives. Sometimes the patient might have taken relatives tablets. Any empty sachets, everything should be sent, especially if you are in a peripheral hospital. If you are transferring the patient to a tertiary care hospital, make sure you send the poison bottle also, because sometimes the information leaflet you have read all the things. So the small printed ones you might not have seen properly. So better to send all the things you have collected there rather than keeping them and sending them back. It's important for us in the tertiary care hospital, and make sure you write a proper transfer form with all the things that you have gathered. And we'll ask whether the patient has vomited at home, and color and the content of the vomiters, any poison particles or tablets. And this is another important question. The time which has taken from for the patient to reach the hospital. It's very important, because again, if the patient has taken about 3 to 4 hours, it determines the rest of the management. And please remember, if you do not attempt the gastric lavage and give activated charcoal in time at the peripheral hospitals, the important time will be lost during the transportation of the patient to the tertiary care hospital. So if you are in a Katagasti or wherever, even if you are transferred to the peripheral hospital after your internship, please remember that the gastric lavage has to be done at the local hospital, because it will take long time for the patient to reach the tertiary care hospital, and by that time important time will be lost. So you have to write what was done at the peripheral hospital clearly also, that these are the important messages that I have to convey, because these things are happening although we tell these things are done by the medical house officers or medical officers in the peripheries. So that's why I'm telling this over and over again. So this is very important message. Now, whenever a suspected poisoning patient comes, if it's a large amount of poison, if patient presents within 1 to 2 hours, you need to exclude any contraindications for gastric decontamination, activated charcoal, and whether the patient has swallowed or skin contamination is there, if it is a sting or a bite, such as in the case of a snake bite. So looks for these things as well. And then if there's any inhalation, skin or eye contamination, and you might have to give a sip of water and wash the mouth, and then get the patient away from the source of poisoning and allow the patient to have some fresh air, run with cold running water or saline ice, irrigate them with saline or running water. Now, if the skin is contaminated, remove the clothes and wash with soap and water. So all these things you need to do. So as I said, you need to consider giving gastric lavage and activated charcoal if a life-threatening amount of poison is ingested. And remember, never induce vomiting. So induction of vomiting is a big no. All right. So when the patient comes to the hospital, how are you going to do the gastric lavage? If the patient presents within 1 to 2 hours of poisoning, according to the national guidelines, we need to give it within 1 to 2 hours, and patient has to be fully conscious also. If not fully conscious, then if the GCS is low, as I said before, if it is less than 10, do it only after cupped ET tube is inserted. That's again very important. So how are you going to do the gastric lavage? Informed consent from the patient or relative. Cuffed DT tube if drowsy and less than GCS of 10. NG tube 18 gauge, Ryle's tube, oral tube also you can insert, and make sure you confirm the correct placement. You can listen over the sternum by injecting some air into the NG tube, or you can aspirate some gastric content and confirm it's coming from the stomach. So those things can be done to confirm, and then you collect the first 50 ml of lavage fluid for toxicological analysis or medical legal purposes. That's very important. And collect the first 10 ml of blood also and keep it separately for toxicological analysis or JMO purposes, because we don't know, the patient might be having a homicidal scenario going on, or some foul play happening. So the JMO will come and ask you, why didn't you preserve some fluid? So you need to do that and clearly label it and keep it in the refrigerator door. You can keep it for some time. And lavage fluid, it's usually normal saline or water. Normal saline, you need to sort of give a lot of normal saline, so just pure water is enough. Okay. A recommended volume of each aliquot is about 200 ml. 200 ml at a time. You insert it and then you take it out. Insert it, take it out. A total of 3 liters of lavage fluid, or you have to perform it until the return is clear. So I think you have got those points. And gastric lavage is not indicated in a struggling uncooperative patient. There is high risk of aspiration, and if the poisonings are due to strong caustic corrosives or volatile hydrocarbons like kerosene or turpentine. So acids, sulfuric acid, those things you shouldn't be doing gastric lavage. Those are contraindicated. All right. Within first 1 to 2 hours is the golden time. But having said that, please remember, if the patient has taken a large amount of poisoning, say for an instance, 100 tablets of paracetamol. So even if the patient presents little late, 6 to 8 hours, we will do the gastric lavage, and it has yielded so much of tablets. All right. So from me to you, the way your gastric emptying behaves is different. So even the guideline says it's 1 to 2 hours. If it's a large poison, you have to try the gastric lavage, and it has to be done at the peripheral hospital or the before you transfer the patient to the tertiary care hospital. So remember that. And especially in extended release preparation, that will be in the gut for a long time. All right. So extended release, low release preparation, then again, you need to do the gastric lavage even if the patient presents late. I told you earlier, if the GCS is less than 10, do it only after cup TT tube. All right. Activated charcoal, again 1 to 2 hours the time. Again, up to 4 hours you can consider for yellow oleander, Niangala, and some slow release preparation. And then for yellow oleander and Niangala, multiple doses of activated charcoal has to be given also. Now it is a black colored dust. You have to dissolve it in water and ask the patient to drink it. Drinking is more comfortable than giving it through the NG tube. But if the patient's GCS is less than 10, of course, you have to give it through the NG. You have to give as a 1 gram per kg also. Usually it comes in a 50 gram, bottles. So dissolve that 50 gram in 200 ml water and then ask the patient to drink it. And if multiple doses need to be given, you have to give it 50 gram every 4 hours. Okay. So there are some contraindications for activated charcoal. If the patient is having compromised airway reflexes, unless the patient is intubated, do not attempt to give activated charcoal because risk of aspiration is high. And if the charcoal is aspirated, that is it. The patient will be having fibrotic lungs for the rest of his life. It's difficult to get the charcoal out of the lungs. And oral intake of caustic substance also, you shouldn't be giving activated charcoal. And then, as I said, very late presentation. And if there are increased risk of severe and severity of aspiration, especially in the case of hydrocarbons ingestion, such as in the case of petroleum and so on. And, for ethylene glycol and alcohol also, that activated charcoal will not get absorbed. So there's no point of giving for those, also. And if the patient needs endoscopy due to significant caustic ingestion, also don't give activated charcoal because you will not be able to see anything if you give the charcoal. And as I said, toxins poorly absorbed by the activated charcoal are alcohols, mineral acids, alkali, iron, and lithium. So there's no point of giving for those also. And if there's any intestinal obstruction, it's an absolute contraindication because, this charcoal can go and impact on the bowel loop. So it's an absolute contraindication. And for decreased peristalsis patient, it's again a relative contraindication. So sluggish bowel movements, again, no. So these are the indications for multiple doses of activated charcoal: yellow oleander poisoning, Niangala, slow release medication, extended release preparation, quinine, theophylline, carbamazepine, dapsone. So these are reasons for you to give multiple doses of activated charcoal. If you do these things, most of the poisoning effects will be reduced. And what are these investigations that you have to do in every poisoning patient? ABG is a must because, you can get a lot of information by doing a quick bedside ABG. There are lots of information such as the status of the, pH, and then bicarb level, calcium, iron levels, chloride levels, and there you can calculate the anion gap, everything will be there, even the CBS. So ECG is very important, RBA is important, electrolytes, ionized calcium and magnesium. If you, balance the ions, most of the time you will, make the patient survive. In every toxicology patient, if you hydrate the patient, unless the patient is having, heart failure or something, preventing for you to give the fluids, you should hydrate the patient well, at least, 120 to 150 ml per kg fluids is necessary. So with the mechanism of the body, it will try to get rid of the poison. So, and the other most important thing is by making sure the patient is having a good electrolyte balance. So if these electrolytes will go, up and down, then the patient will go into arrest, cardiac arrest. So please remember to make sure that the patient's electrolytes are okay, and have a look at the CPK, liver functions, INR, APTT, and the renal functions also in poisoning patient. So what are the common poisons for which the antidotes are available? So organophosphates, atropine and PAM, carbamates, will give atropine only, paracetamol, N-acetylcysteine or methionine, benzodiazepine, fulmoxanil, digoxin and Caneru. Digitab is not available in Sri Lanka. Propanil poisoning, methylene blue. And for methanol and ethylene glycol, you have to give alcohol. Omeprazole is not available in Sri Lanka. For calcium channel blockers, insulin dextrose therapy, HIAT, HIET, high insulin euglycemic therapy. You have to start very quickly. Calcium gluconate also you can try, beta blockers, glucagon, insulin, dextrose, for iron, desferrioxamine, and for opioids, naloxone. So this is actually important for you to have a little understanding about the antidotes. So a little bit about the paracetamol poisoning. Single overdose of more than 10 grams, 20 tablets, or more than 200 milligram per kg is potentially fatal. So how are you going to calculate your dose? We don't have this nomogram now to check the levels. Usually you can check it at 4 hours paracetamol levels. And if the level is, we can place this in the paracetamol nomogram, you can see at 4 hours. And if it is more than that, you can give the medication, antidote. But if the patient is, patients are high-risk patients, such as in the case of patients who are having low, patients who are having already compromised liver functions, alcoholics, patients who are very having anorexia nervosa, bulimia nervosa, patients who are on liver enzyme induction drugs. So all these patients comes in the high risk group. So for these patients, you have to start the NAC little early, NAC or methionine antidote little early. Now we don't have these paracetamol number. So what are we going to do? So we will be doing the weight adjusted dosage. How are we going to calculate it? You have to multiply the strength of one tablet. Say if it is the patient has taken 10 tablets, one tablet is 500, 500 into 10 is 5,000. And you divide it by the weight of the patient. Say the weight is 50, you divide it by 50. So if that dose is more than 150 milligram per kg, you have to start treating the patient. Understood? So 500 milligram into the strength of one tablet is 500. You multiply it by the amount of tablets the patient has taken and divide by the weight. All right. So if it is more than 150 milligram per kg, you have to start treating the patient. So what to give? NAC and methionine. Superiority of NAC or methionine is not proven. Methionine is as effective as NAC according to the available researchers, but NAC is expensive. So it's a clinical decision. If the patient has taken about 154 milligram per kg, you can use methionine safely. The patient is not vomiting because methionine is an oral tablet. NAC is oral and IV, both are available. Okay. So as I said, if patients present within 8 hours, you can give methionine because methionine is not effective after 8 hours. Asymptomatic patients with a low, marginal high dose, you can try with methionine. And methionine is not recommended to start later than 10 to 12 hours after the ingestion or if there's already established liver injury. So NAC, again, if the patient presents 8 hours after that, you can start NAC. But having said that, please remember NAC is also very effective if you give it within 8 hours. All right. So that is also there. So if it's a patient who has taken a huge dose of paracetamol, better to start with NAC. So it's a clinical decision. You can take the senior's opinion also with regard to this. If you happen to give the oral methionine, for adults and children weighing over 20 kilograms, 2.5 you give initially and followed by 3 more doses of 2.5 given 4 hourly. All right. Methionine for children less than 20 kilogram, methionine you give 1 gram orally initially and then followed by 3 doses of 1 gram 4 hourly. In elders, it's 2.5. In children, it's 1 gram. Total dose is 4 grams. So if the PCM levels are available, I told you earlier, you need to plot it in the nomogram. If the above the treatment line, you can continue NAC. Okay. Then antidote is again indicated if time of injection is not known or more than 24 hours have gone and patient is clinically symptomatic. And you need to check the AST and ALT and INR. And if they are increased, you need to continue the NAC. So exactly how to, stop NAC and everything, I have not touched upon here because it's another topic. So you can take the senior opinion. So how to give NAC? Now, this is important. Now, poison book says 3 bag. Now, this is what we are using 2 bag method. That's to prevent, anaphylactoid reactions from happening. With paracetamol poisoning, there can be vomiting, but with NAC also there can be increased vomiting due to anaphylactoid reactions. There can be flushing, itching, nausea, vomiting, everything can happen, and even anaphylaxis can happen with NAC. So to prevent that, we have to give the first bag 200 milligram per kg within 4 hours, and the second bag 100 milligram per kg within 16 hours. That's how we give. Initially, we gave the first bag within 15 minutes, second bag within 4 hours, and the third bag within 16 hours. So we have stopped that. Now we are giving, within 4 hours the first bag to prevent the anaphylactoid reactions from happening. So a little bit about the plant poisons. So I hope you can identify this plant. Is it Kaneru, Diya Kaduru, Koda Kaduru, Olindo, Niangala? So actually this is a Diya Kaduru. I think, all these coastal areas will have these, plant poison. And this is of course found everywhere. I hope you know this. So it's actually a Kaneru poisoning. A little bit about, Kaneru. Again, whole bowel irrigation will be helpful, gastric lavage, and give multiple doses of activated charcoal. Anti-digoxin-fab antidote is not available in Sri Lanka. You need to monitor the serum electrolytes very carefully in these patients because hypokalemia and hyperkalemia both can happen in Kaneru poisoning. Hypokalemia can happen due to a lot of vomiting, and hyperkalemia is a feature of Kaneru poisoning. Now, digoxin toxicity will be increased. Already existing digoxin toxicity will be heightened if the patient is having hypokalemia. So make sure that you maintain the potassium in the normal range. And cardiac pacing will be needed if there's any second degree or third degree heart block with unstable blood pressure, because they can have any arrhythmia possible. Any arrhythmia is possible with Kaneru poisoning. If BP is normal, atropine is not needed. If the pulse rate falls less than 40 per minute only, you have to consider giving atropine. If the blood pressure is normal, you can just safely wait. And insulin dextrose is given for hyperkalemia with sodium bicarbonate. But remember, you should not give calcium gluconate when you give insulin dextrose in a case of hyperkalemia, especially in a Kaneru poisoning, because that can result, stone heart. You can read around it, and there can be increased dysrhythmias also. So in summary, first do the ABCD assessment to stabilize the patient. The induction of MSH should not be done. Rhesus RSI dead pathway is very useful in managing patients with poisoning, and focus history with collateral information is essential. And atropine is indicated early in the OP poisoning when patient presents with cholinergic crisis. And atropine infusion is to be continued after loading dose, and get your seniors involvement early. Thank you very much. And as Dr. Kumudini Jayasinghe mentioned, happy internship. This is the most important time in your life, and make sure you take the use of it. Thank you very much. Wish you all the best. And if there are any questions, you can forward it to the chat box. I can answer.
Right. Thank you very much, madam, for that detailed lecture on poisoning. That was Dr. Madhuvanti Etiarachi, consultant physician. As madam said, if you all have any questions, please use the chat box to chat. At the meantime, we are going to the next lecture is by Dr. Bandhusi Ratnayaka, consultant physician at Teaching Hospital Ratnapura, on the theme of approach to a unconscious patient. So over to you, sir.
Roshan, can you hear me?
Yes, sir. Madhul, sorry. Yes, I can hear.
Okay, right. Thank you.
Sir, need to make it full screen.
Now that's okay, no?
Yes, sir. Now you're okay to sir. Go.
Oh, right. Thank you, Roshan. So good morning, everybody. I'm Dr. Bandhusi Ratnayaka, consultant physician from Teaching Hospital Badulla. So my task is today to discuss about the clinical approach to a patient with altered level of consciousness. This is the outline of my presentation: definition, causes, evaluation, management, and prognosis. So we will define few terms before making the before making the clinical approach. So what is consciousness? It is simply mean awareness of both internal and external stimuli. Now, as a pre-intern, what you all are doing now, you know that you all are now listening to my lecture. At the same time, you know what is happening around you. So that is consciousness. So defined as being awake and aware of both oneself and the one surrounding. So if there is a level, yes, definitely there is a level. So level of consciousness is a measurement of a person's arousability and the responsive to stimuli from the environment. So there are a few terms we have to define before we discussing to unconsciousness. And confusion or confused patient. What is confusion? So disoriented to surrounding, may have impaired judgment, may need some cues to respond to commands. So there is another term called lethargy. It's like a stimulate, like a light sleep. The patient is arousable, but touch or noise and can maintain alertness for a period of time. So patient is like a deep sleep. So you can call the patient, hello, hello. You can call by name, Nandasena, Nandasena, you wake up. So then he wake up and then again go into sleep. So that is a lethargy. Obtuntation. Obtuntation means the response slowly to external stimulation and need repeated stimulation to maintain attention and response. So there is another important term, stupor and coma. What is stupor? Stupor can be aroused only by vigorous stimuli. Whereas in the previous one, if you call the patient, in the lethargic patient, they can awake. But you need to give a vigorous, hard stimuli. Effort to avoid stimulation are displaced. So when you are, so the common thing, we press, we make a clench and press on the sternum in unconscious patient to assess the responsiveness. So when the patient, if in stupor position, they try to avoid that stimulation, try to take our hand away or likewise. So little or no spontaneous activity and shows little motor or the verbal activity once aroused. Once aroused, there is a very little motor activity and the spontaneous activity. The worst case scenario is a coma. That is if you talk about the level of consciousness, the worst level of consciousness is a coma. The patient is not arousable at all. That is a key word, right? So the patient is not arousable at all to verbal or physical stimuli. So however much you shouted at the patient, no response. However much you give a vigorous stimuli physically, right? No response. And no attempt is made to avoid painful or noxious stimuli. If you give painful or noxious stimuli, no response, right? But his heartbeat is working and his breathing is working. So those patients are called as a coma patients. So definition is coma. Now you can see level of consciousness is a spectrum of status. You know that spectrum, right? Spectrum. So for example, ischemic heart disease is a spectrum of disease. One end there is a stable angina, other end ischemic cardiomyopathy. In between there is a unstable angina, non-ST elevation MI, ST elevation MI. Likewise, level of consciousness, there is a spectrum of status between normal and coma. There are confusion, delirium, lethargy, obtuntation, stupor, right? So this is a unconsciousness. If you assess the patient, it is a subjective variation. Your co-house officer will say, Majam, that patient is unconscious. Nurse will come and say, doctor, that patient is semi-conscious, right? Some other, the minor star patient will come and say, doctor, that patient is in confusional state. So to avoid this subjective variation, the scientists got together in Great Britain, place called Glasgow, and they made this scale. So there are 3 components: eye opening, best verbal response, and the best motor response. As long as you are working as a doctor and an intern especially, you should know the component and all of the GCS, and how to assess the GCS is a basic requirement of an intern house officer in whatever the ward, gyn and obs or the pediatric or whatever the ward, wherever you work, you have to assess. So there are components. I am not going to describe it. What is the importance of GCS when you are handing over the patient to the somebody, or when you are transferring the patient, right? Say suppose I am transferring patient from Badulla to National Hospital Colombo, right? So I have to write down the GCS is 9. If the receiving end patients, by the time the patient received Colombo, so GCS is 7, they know that there is a in between, something has happened to the patient. When you are handing over the patient to your colleagues, when you finish your night duty and you hand over to the co-house officer, then you hand over this patient is GCS is 10. You have to mention that what is the each component, eye component, verbal component, and the motor component. So that is the importance of maintaining GCS. That is a basic requirement of all the doctors. You have to best practice this one and apply to your day-to-day practice and register in your main. Can anybody tell me what is the main drawback of GCS? Glasgow Kema, there is one drawback. What is that? If you get a no response, you will get 1 mark. No motor response, 1 mark. No motor, 1 mark. Even a dead person has a GCS 3. Once I remember when I was working in a Monaragala hospital, one house officer came to my room and said, one patient got admitted with a GCS is 3. First question I asked whether he dead or alive, right? So in a dead person also GCS is 3. So in live patient also you can get GCS 3. So you have to keep on that fact. You have to remember that. What are the common causes for the loss of consciousness or unconsciousness, or raise the diverse pathophysiologies: hypoxia, nutritional deficiency, trauma, medication, electrolyte disturbances, encephalopathy, infection, stroke, pain, seizures, right? So this graph shows that another causes in a different heading: infection, toxic, metabolic, like all the electrolyte disturbances, like endocrine disorders, hyperglycemia, hypoglycemia, low sugar, hyperadrenalism, hypo, right? Hepatic encephalopathy, uremia. In the hypoxia and the hypercarbia, also it's a well-known cause for the unconsciousness, congestive cardiac failure, pulmonary embolism, COPD. If you consider the cerebrovascular things and the trauma, CVA, either hemorrhage, the ischemic, and the central nervous vasculitis, so the causes are diverse, right? So if you get a patient with a coma or unconscious patient, so this slide shows that the basic summary what to do, but we will discuss one by one. So coma is an acute life-threatening condition and evaluation must be swift, comprehensive, right? It should be very quick and it should be comprehensive. You have to start with the resuscitation of patient by maintaining the airway breathing circulation. Airway breathing circulation, ABC approach. Any unconscious patient, any emergency, that is the usual accepted management protocol. So you have to follow. And glucose and thiamine and oxygen. So those are specific thing and the very basic thing. And on admission, you have to check the blood sugar level. If it is a hypoglycemia, you have to give it. If the patient is alcoholic and coming with the severe unconsciousness, you have to think about to giving IV thiamine. And if patient is hypoxic, you have to give oxygen. Hello? No. Yeah, I am in a Zoom meeting and I will call you in 30 minutes. Right. Diagnosis and evaluation and therapy and the continuing care. So we'll go by one. When you consider we have to consider when we go to the history component of the history. So the quick history. So when it's a common for all emergencies. So you have to, you can't take you can't take hours and hours when you are managing an emergency, right? So unconscious person we call as is a medical emergency in a medical ward. If you get the unconscious patient during your casualty night, so you have to act quickly, right? The quick history, right? And then they gather all possible information from the relatives, paramedics, ambulance crew, and bystanders, right? And so if they are available, you have to gather as much as the possible. So onset is the most important thing as far as unconscious patient management is concerned, whether this is abrupt onset or the gradual onset. If relatives say that, doctor, this patient was up and about and he was watching his mobile phone, all of a sudden he became collapsed. So that is abrupt onset. You have to think about your differential diagnosis are different. So if it is a gradual onset, this patient had a fever and cough for a week ago, then he stopped his eating and drinking, and he become a reduced level of consciousness. Today he become unconscious. That is gradual onset. So that is the most important thing in the history. Onset of onset, whether it's an abrupt onset or the gradual onset. So any suicidal notes, it is important as far as the drug overdose is concerned. So in the depressed patient, usually before they get a suicide, they put a suicidal note. Right? And the seizure history. So this patient might be in the post-ictal status. Nobody has seen that. If the patient is a known patient with seizure, came to unconscious, you have to suspect whether this patient in the post-ictal status. So any head injury, headache, recent illness, and under the past medical history, diabetes is one of the most important metabolic condition if you consider when you consider the unconsciousness. And the liver, renal, and the seizure disorder I mentioned, and the alcohol, drug, and the psychiatry history. And remember that the check medication, right? Check medication. If the family members, relatives don't know anything about the patient, ask about what medication he did. You have to check the balanced medicine with the patient was drug overdose. Those are the things, right? Examination, the level of GCS will determine the speed of examination. So if the GCS is 15 out of 15, so no need to much worry about. If the GCS is 8, then that is alarming thing. Sometimes patient might need intubation. So general go through the general examination as much as possible. So if you get a relatives or the known persons or the somebody known to patients and can give the history, that luxurious. But your challenge is in a medicine, when you get an unconscious patient in a casualty day, you suppose that you are the only person, you are a house officer working in a medical unit or pediatric unit, you get an unconscious patient, nobody, brought by the police or brought by some other patient not known to the patient. Then you can't get the history, right? They don't know anything about the patient, but believe your 5 cents. Right? Believe your 5 cents and try to examine as quickly as possible and gather information as much as possible. Then you can get several clues. So what are the things you look for? Under skin, cyanosis, discoloration. It's a very important sign. Rashes, could be a dengue hemorrhagic fever. It could be a meningococcal rash. Pallor, right? If the patient is pale, it could be some hypovolemia or hemorrhagic shock. So icterus is one of the important physical signs. I am always telling to my house officers, never ever miss this physical sign. Jaundice or icterus or yellowish discoloration. If it is there, always it is pathological in an unconscious patient, right? And the needle marks for the drug abuse. And the petechial hemorrhages, that's important in certain condition, and the stigmatas of the peripheral stigmatas of certain disease. CLCD, there are 15 peripheral stigmatas in a CLCD patient. You have to know that patient is unconscious, nobody is there. Patient has a CLCD peripheral stigmatas. Think about the hepatic encephalopathy, right? CKD patient. there is a uremic frost and the peripheral stigmatas of uremia, dialysis mark, and think about the uremic encephalopathy. So patient has a diabetic peripheral stigmatas like injection marks, and then the neuropathic ulcers, foot ulcers. So think about the hypoglycemia or the hyperglycemia. Right? Smell is also important. That's why I said you have to master your 5 senses. If your nose is working properly, alcohol smell, you should be familiar. This patient under the influence of alcohol. So this must be a alcohol-induced hypoglycemia or alcoholic unconscious. The hepatic feto is a classical smell coming from the patient with the hepatic encephalopathy. So ketosis, classical smell coming from the patient with the diabetic keto. So that is why by doing when you are working in a clinic, medical ward, surgical ward, you will get this sense. So master your smell sensations. So uremia, fever, hypothermia, signs of trauma, hematoma, bruises, lacerations, you can obviously diagnose. There are certain clues. This slide shows you that if till certain the physical signs which give rise to the underlying pathology. If the patient is ill, cerebral malaria, though it is rare, you can get. Recently, I got a patient from Lebanon and a foreigner. He had a very severe falciparum malaria, managed in the ICU and recovered. And I sent him, and he sent me a message yesterday thanking for everything you have done. See, you saved my life. So remember that if a foreigner comes with the fever, don't forget malaria, even though our country is a malaria eradicated country now. Intracranial bleed and the hemolytic HUS, you have to think about the pale unconscious, icterus unconscious. What are the possibilities? Hepatic encephalopathy, I mentioned, could be a leptospirosis, could be a complicated malaria. Rashes, meningococcal rash. The last month there was the outbreak in southern province, right? In the teaching hospital, Karapiti got several the patients with meningococcal meningitis. Outbreak happened in a prison, Dadal area. So the meningococcemia, dengue, measles, rickettsial, and the arbovirus. Those are the illnesses can give rise to rashes. Petechial hemorrhage in the dengue, meningococcemia, hemorrhagic fevers. What are the hemorrhagic fevers in medicine? There are 3. One is dengue hemorrhagic fever. Second one is a leptospirosis. Third one is a hantavirus. There is a 4th one, rare Korean hemorrhagic fever. So head and the scalp hematoma could be a trauma and any head injury, right? The patient is unconscious. The dysmorphic features like the neurocutaneous markers. What are neurocutaneous disease? The diseases which involve the central nervous system and the skin. We call as neurocutaneous. So there are 4 neurocutaneous diseases in medicine: Sturge-Weber syndrome and tuberous sclerosis, and von Hippel-Lindau disease, and the neurofibromatosis. So if the patient is saying unconscious, you detected the neurofibromatosis or the Shagreen patches or the adenoma sebaceum in the face. So underlying diagnosis is tuberous sclerosis. The patient might be has a post-ictal status. So abdomen odor, I mentioned, right? So under the vital signs, certain vital signs are important in assessing the unconscious patient. Say, suppose the patient is having high fever. Patient is unconscious, nobody is there, but patient is having unconscious patient with high temperature. Think about the infection. It could be a encephalitis, the meningitis, meningoencephalitis, endocrinopathy like a thyroid storm, thyrotoxic crisis, right? Environmental conditions like a hypothermia, hypothermia, or the any drug overdose like a neurotoxicology. The previous lecture you heard about the certain drugs can cause giving rise to a high temperature. We call as a neuroleptic malignant syndrome, especially drugs with a sympathomimetic. The respiratory rate, patient is tachypnic, especially in the diabetic keto. Patient is the unconscious, patient respiratory rate is high. So tachypnea, think about the sepsis, diabetic ketoacidosis, and the salicylase overdose. And the patient blood pressure either low or high. If the high blood pressure, hypertensive encephalopathy or ICH patient. Heart rate, either bradycardia or the tachycardia, endocrinopathy, cardiac causes, and the toxicology. causes, and the infection, certain infection can cause, like you get a relative bradycardia, like in a typhoid fever, right? Hypoxia, infections, infarction, substance overdose. So after the general examination, the next best important thing is a neurological examination. That is a cornerstone of the assessment to define the nature of the coma. So it should be a descriptive and the systematic way, and the lateralizing signs are the very helpful to come to a definitive diagnosis. So unequal pupil, unconscious patient, unequal pupil. Important, very important, very important. Right? Deviation of eyes to one side in unconscious patient, very important, right? And the facial asymmetry, very important, right? Because I can remember when I was in Ratnapura, one house officer telling, so patient is unconscious, I couldn't do a CNS examination, right? Is that correct, Christian? No, that doctor doesn't know how to examine the limited central nervous system in unconscious patient. Right? Facial asymmetry, that is an inspection, right? No need to, the patient, no need to go, come, I know that it is difficult, but that is a challenge. That is a target. So always intern should take a challenge, right? So medicine is a challenging field. So you should get this challenge and come to a consensus, right? Okay. And turning of the head to one side is important. Unilateral hypotonia could be a stroke. Asymmetrical deep reflexes, absent or exaggerated, is an important physical sign. Unilateral extensor plantar, right? So the plantar response, it is important, right? Okay, so neurological assessment, basically we can categorize under 4 heading: respiratory pattern and pupillary light reflex, spontaneous eye movement, and the motor response. If you consider the pupillary reflex, pupillary pathway is near the reticular formation, and the pupillary pathway is resistant to the metabolic insult. Usually when there is a metabolic derangement, the pupils will not be affected. Single most important physical finding to distinguish structural versus from the metabolic. If you get a patient with unconscious person, you have to ask yourself whether this is a structural disorder, if this patient is having, whether this is a metabolic disease. So one of the important things is a pupillary reflex. So bilateral enlarge and the non-reactive pupil indicate massive CNS infection. So it could be anoxic and the barbiturate poisoning, severe hypothermia, anticholinergic poisoning. So pinpoint pupil could be a pontine lesion. So previous lecture you heard about this thing, right? Opioid poisoning. So well-known, very known physical sign. If patient is unconscious, patient has a bilateral pinpoint pupil, think about opioid poisoning, right? OP poisoning, right? Opiate, OP poisoning, and pontine lesion. And unilateral fixed dilated pupil, usually equilateral expanding mass-like lesion, right? Okay. And this is the same thing with the eye movements. If you get that, there are 2 types of eye movement. Persistent deviation to the one side may indicate 2 types of lesion: irritative lesions or the paralytic lesion. Irritative lesion away from the lesion, the paralytic lesion towards the lesion. If you say with the patient with a Gates palsy, patient is unconscious, right? Now patient is eyeball is deviated to the right side. So 2 possibilities. What are the things? It could be irritative lesions in the left the cortex, or the paralytic lesions in the right cortex, right? Structural brainstem lesion abolish the conjugate eye deviation. And there are 2 important reflexes: vestibular reflexes and the oculocephalic reflex, right? So you turn, when you are turning the patient to the left, usual response is the eyeball move to the right side, right? And if it is not, it is absent, we call as a oculocephalic reflex is absent, right? Caloric response, the normal tonic response is when you inject the normal saline into one eye, then there will be a asymmetrical response. If it is response is not there, so that's also important eye response, right? So under the motor examination, the bulk of the muscles, you have to know that the tone, spontaneous movement, whether there is a asymmetrical reflexes, hyperreflexia indicate the upper motor nerve lesion, hyporeflexia, absent reflexes will indicate the paralytic lesion, right? So what are the laboratory tests in the patient with the Unconscious patient, glucose, very important thing. In ETO and admission, you have to do that, the CBS monitoring, blood sugar monitoring. If it is a hypoglycemia, you have to treat it vigorously, and hyperglycemia, also you have to treat it. Electrolyte disturbances, hyponatremia, blood urea creatinine indicate that you can diagnose whether this patient is having a uremic encephalopathy. Serum osmolality, hyposmolar coma, like in the HHS and the ABG is one of the important thing, and you can get a hypercarbia, hypoxia, right? And the troponin is important, whether this patient had acute coronary syndrome. Full blood count, CRP, tell us the infections and the thrombocytopenia, whether this dengue hemorrhagic fever or sepsis-induced thrombocytopenia. Coagulation profile, whether the patient is going for a DIC, and the calcium, magnesium, liver function test, and the toxicology screening, Madam told in the previous lecture. If you are suspecting drug overdose, please take urine within 24 hours and send for toxicology screening. It is done in my hospital, so it is very important. So without giving any treatment, take the urine sample. After 24 hours, all drugs metabolize, no need. So urine analysis and the blood culture. So other things, CT scan, we need most of the time, and sometime MRI scan can detect hemorrhage, hydrocephalus, or infarctions or edema. We need sometime lumbar puncture to diagnose meningitis, encephalitis, or sometimes subarachnoid hemorrhage to look for the CSF xanthochromia. EEG, post-ictal non-convulsive status epilepticus, we can diagnose by EEG, ECG, and the testing. So when you come to management of unconscious patient, assure the oxygen. The goal of medical management is to preserve brain function and prevent further damage. So assume the assure oxygenation. If it is hypoxic, you have to give oxygen and maintain perfusion. That is the ABC management. Basically, give glucose and thiamine. If you suspect this patient with hepatic encephalopathy or this the alcoholic patient, you have to give thiamine first before giving alcohol, the glucose. So neurosurgical team evaluation and the stop seizure by giving anti-seizure medication and restore acid-base balance after doing a ABG. If there is a severe acidosis, you might have to correct it. And glucose control, we mentioned either hypoglycemia or hypoglycemia. If there is an infection, you have to treat vigorously. Early antibiotic after taking culture is the practice. Right? Early nutrition is most important. DVT prophylaxis, antipyretics. In the fever with the unconscious patient, you have to treat fever vigorously and the corneal protection. Right? So airway intubation. So sometimes we might need to intubate the patient, but it is beyond your scope. Remember that, beyond your scope, and always discuss with your senior. As a house officer, you can't take a decision, the patient, whether going to intubate or not. Right? Important to take an entire clinical picture. If patient is the patient entire clinical, so sometimes the patient is 35. It's a very advanced cancer with all metastatic, terminal care. Do you intubate? No. Right? So you can't, you have to have an overall picture. Inadequate ventilatory support and impending airway loss from the neck or the pharyngeal injury, and the poor airway protection due to decreased level of, usually if the GCS is level 7, the less than 7, usually we intubate, but make sure that the patient is having not hypoglycemia. That is why I said that do a CBS. If the CBS is low, correct it before intubation, right? Rule of thumb is GCS less than 8 typically require intubation, right? And as the summary, approach to a patient in coma requires a systematic examination that will then direct diagnostic testing. Approach to a patient in coma requires the systematic examination that will then direct diagnostic testing. So that is why I said that is the bad trend by the lot of the current passing out doctors, right? And when they come to do an intern, they are not taking proper history, not do a proper examination, and order investigation A to Z. Irrelevant investigation, and so it's utter wasting of resources. So in any emergency, any unconscious patient, go through, try with your best to come to a possible differential diagnosis and then plan for an investigation. So CT scan not for all the patient, right? Okay, so GCS score is helpful in providing a baseline for the comparison, but it is not prognostic in non-traumatic brain injury, and the prognosis is better with toxic metabolic rather than the structural damage. If it is a toxic and the metabolic causes, the prognosis is good, but it's a structural patient met with a road traffic accident, brain contusion, and the recovery is delay, prognosis poor. The clinical examination and now EEG has a major place in current practice, maybe the best predictors, right? So with that, I will conclude. Thank you for your patient listening. If you have anything, you can put into the chat box.
Thank you very much, sir, for that detailed lecture. So we're going to go. We have tea break now. So from 10 to 10:30. So we can take this time to ask some questions. If you're having any questions, please use the chat box or unmute and ask. Please.
Somebody has asked, sir, can we have the slides? Of course, I am happy to send slides. I think I can send it to Roshan.
Yes, sir. Well, plus, this is on the YouTube live broadcasting, so it's there as well. So those who can go to the YouTube link and they can always refer that also.
Oh, that's lovely. That's fantastic, Roshan. Okay, anybody wish to see the slides, and then as Roshan said that go to YouTube and see it.
Yeah. Right. So if you all have no questions, we will take the tea break. So thank you very much, sir. Consultant physician, Dr. Bandusri Ratnayaka from Teaching Hospital Badul. It's a Badul, no?
Yes, Roshan. Thank you. Thank you, Roshan.
So for that comprehensive lecture on approach to unconscious patients. Thank you, sir. Right. Welcome back after the tea break. So next up is another important lecture by Professor Manoj Patirage on initial management of hypertensive emergencies and acute heart failure. I think Sir has joined in. I hope Sir can hear. So can you hear?
Yes. Yeah.
Yeah, madam.
Yes.
Sorry.
Yes. Yeah.
Manoji, I'm sorry. Uh, there are 2 minutes more, but we can start sharing the slides and do the initial.
Yeah. So, give me one second.
Madam, your voice is a little bit faintish. Can we increase the volume on the computer?
Now how it is?
Yeah, better, madam.
Okay. So I cannot see the screen.
Madam, it's not full. You have to make it something wrong.
Yes.
It's not. Yes.
Yeah,
Yeah. You have to make it slide mode. Yeah, presentation.
Right.
Right.
Now it's okay.
Can
No?
start. Yes.
Yes. So shall we start now?
Yes, madam. Can start. Yes.
Okay. So good morning, everybody. So it's my task to talk about another important topic. So first of all, we will go through few case histories. So the first case history is a 65-year-old male, previously apparently well, sudden onset right-sided face arm limb weakness for 1 hour duration. On examination, this patient is having right-sided hemiparesis with a blood pressure of 210 by 130 millimeters mercury. And the non-contrast CT brain is normal, and he has no apparent contraindication for thrombolysis. So this is about the first case. So I think now you know that we are going to talk about the first case of acute stroke, as the CT brain is normal. It is acute ischemic stroke. Then the second case, it is a 55-year-old lady, 2 hours history of retrosternal chest pain, which is radiating to the back, and interscapular pain as well. This patient's blood pressure on her right arm is 220 by 120, and the left arm is 150 by 70 millimeters mercury. And pulse examination, there is a pulse discrepancy with a ECG, which is showing acute inferior myocardial ST elevation myocardial infarction. And later, because of the blood pressure discrepancy, the CT aortogram was done, which confirms that patient is having aortic dissection. So the third case, it is a 25-year-old lady on in her first pregnancy with the POA of 34 weeks, who is a defaulted follow-up, who is not on any antihypertensives, and admitted to the obstetric ward with a 2-day history of headache, epigastric pain, and generalized body swelling. On examination, she's having facial puffiness, body swelling with ankle swelling, and the blood pressure is 200 by 100 millimeters mercury. Soon after the admission, patient has had a severe abdominal pain, and then she has had a generalized tonic-clonic seizure.
so soon after the admission. So that is about the third case. And for today, the final case is a 55-year-old male who admitted to the hospital with acute onset severe shortness of breath for 4 hours duration with a respiratory rate of 30 breaths per minute, blood pressure of 220 by 130 millimeters mercury, and on auscultation, patient is having bilateral fine crepitations in both lung fields up to mid-zone. So you may wonder why I just presented these 4 cases. So I would like to emphasize there is a similarity in all 4 cases. So the first case, it is a stroke with a blood pressure of 210 by 130. The second case is a dissection with ST elevation MI. And that patient is also having the blood pressure of 220 by 120. The third case is a pregnant lady coming with epigastric pain, headache, and body swelling. Blood pressure is high and patient has developed a fit, which is a preeclampsia. And the fourth case is a patient who presented with shortness of breath and having high blood pressure. This patient is having acute heart failure. So there is a similarity for all 4 cases. That is none other than very high blood pressures. So all 4 cases, the blood pressure is the problem, which is very high. So therefore, we are going to discuss the management of hypertensive emergencies and acute heart failure. So I hope that you know what is the definition of hypertensive emergency. The very high blood pressures. So usually in the hypertension nomenclature, so you call if the blood pressure is above 130 by 80, you call that patient is having not normal blood pressure. So if a patient is having blood pressure 131 to 140, you call it as higher normal blood pressure. But if the blood pressure is above 140 until up to 159, you call as hypertension grade 1. And if the blood pressure is more than 160, you call it as hypertension grade 2. Having said that, if a patient is having very high blood pressures and patient is having evidence of target organ involvement, that means brain, eyes, heart. So if it is a pregnant lady, it is like fits and eclampsia. So then hypertensive emergency. So if there is no target organ involvement, but the patient is having very high blood pressures, you call it as hypertensive urgency. So the urgency and the emergency, the difference is when there is a target organ involvement, you always call it as emergency. A little bit of pathophysiology. You may think that why this person is telling about the pathophysiology, but it is really needed to understand the process. So there are 3 things are going to get activated: endothelial injury or endothelial dysfunction. There will be a pressure natriuresis, an increased vasoconstrictors, and decrease in the vasodilators. So all 3 will cause activation of the procoagulation cascade and inhibition of the fibrinolytic mechanism. And from the other end, there will be release of inflammatory markers and reactivation of the oxygen species. And then volume depletion and positive feedback to the renin-angiotensin system will be happening on the other side. So these the previous 2 will cause fibrinoid necrosis and myoproliferation. So it will further increase the blood pressure. So this is the normal pathophysiology of how a person gets very high blood pressures, sudden onset very high blood pressures. So having said that, as I told earlier, the definition of hypertensive emergency is when a systolic blood pressure is more than 180 millimeters mercury and the diastolic blood pressure is more than 120 millimeters mercury, with either impending or acute target organ damage, you call it as hypertensive emergency. So to say the emergency, you need to demonstrate that there is a target organ involvement. So these are the target organs. Patient can get features of heart failure. Patient can get acute aortic dissection. Patient can get acute myocardial infarction. And there will be acute kidney injury. And there can be acute cerebral ischemia or bleeding into the brain. And if the patient is pregnant, that person can get preeclampsia or eclampsia. So these are the things that you should know. So therefore, this picture is really, if you can remember this picture, you know that what are the hypertensive emergencies. So these are the target organs. Heart, you can get acute LVF and acute coronary syndrome. If it is the brain, patient can get hypertensive encephalopathy, acute ischemic stroke, or intracranial bleeding. If it only affects the eye, there will be retinal hemorrhages and papilledema. So if the liver is going to get involved, you can get acute liver injury. And if it is the kidney, you will get acute kidney injury. If it is a large blood vessel, you get the aortic dissection. And when it goes to the hematological system, you will see microangiopathic hemolytic anemia. You call it as MAHA, or that is the main feature in the hematological abnormality. So if the blood pressure is more than 120 by 180 by 120, you will look for whether the patient is having target organ damage, acute onset, or whether the patient is in impending target organ damage. Of course, you have to be more vigilant. Now I'm going to dealing with a hypertensive emergency. So you will take a quick history and do the quick examination, and you have to rush for the investigations because you have to start the treatment as soon as possible. So history, you have to get the quick targeted history to rule out myocardial ischemia, acute stroke, acute kidney injury, and the acute heart failure, and just to check whether the patient is pregnant and patient is in second trimester or third trimester, to call it as preeclampsia or eclampsia. So on examination, you are going to check the blood pressure, which will be definitely high, and then you are going to check the blood pressure in both arms. So if there is a discrepancy, you know that you are dealing with a patient with possible aortic dissection. So therefore, you are going to palpate the pulses and check whether there is a radial delay or radiofemoral delay, and what about the lower limb pulses as well. And when you are auscultating in the heart, if you hear a gallop rhythm with a tachycardia, you know that it could be due to heart failure. And then you will auscultate the lung fields for the bibasal fine and inspiratory crepitations. So in your neurological examination, if a patient is having hemiparesis, which will indicate acute stroke, and when you look at the fundus, if there is papilledema, once again, this could be due to hypertensive emergency, or if you have seen retinal hemorrhages, it implies that you are dealing with a patient with hypertensive emergency. So in the abdominal examination, if you detected a pulsatile mass, it could be aortic aneurysm. So therefore, these are the key things that you have to do in general and systemic examination of patient with hypertension. So next, you have to rush for the investigation. So initially in the ED emergency department, you provide a patient to the acute bed, and you are going to keep him comfortably, and then put the oxygen if needed, then connect the patient to the multi-para monitor, and you need to get the IV access. At the same time, you better take blood for necessary investigations. So if you think that this is acute coronary syndrome, if ECG shows ST elevations, you have done. But if there are deep T inversions, you may wonder whether non-STEMI, so then you can take blood for troponin. And if it is heart failure, if you really need to confirm, you can do the heart failure, other investigations like BNP and other things, but heart failure will be a clinical diagnosis. And then you better send blood for the full blood count and arrange, if you are thinking this could be the hypertensive emergency, arrange urgent blood picture just to exclude MAHA. So this is really going to matter with the maternal patients as well, because they are, the blood picture is really necessary, full blood count is really necessary. With the preeclampsia, they can get low platelet counts, and then you need to send SGPTOT levels just to see liver involvement, and get a blood for serum creatinine levels to see whether the patient has got acute kidney injury as well. And you need to do the ECG just to see whether there are evidence of acute ischemia. And you need to do the urine pool report to see whether the patient is having acute urinary sediments, which gives a clue to say that this patient is having acute kidney injury. So the next one is if patient is having focal neurological signs, especially the features of hemiparesis, you are going to do the CT brain, which shows if there is a hemorrhage, which will be evident. And if it is so acute stroke, ischemic strokes, you may not be able to see on the CT brain. So you are doing the CT just to exclude the bleeding manifestations. And if you suspect aortic dissection with the history of sudden chest pain, radiates to back interscapulous pain, and if there is a blood pressure discrepancy and pulse volume rate discrepancies, so you may have to think about whether I'm dealing with an aortic dissection. So then we have to go for a CT aortogram as well. So these are the important initial investigations. With the available facilities, you can do much more investigations as well. So now, you know now the blood pressure is more than 180 by 120, and there are evidences of target organ involvement. So the final diagnosis is patient is having hypertensive emergency. So in hypertensive emergency, the management will depend on the selection of the drug, what is the route of admission, what is the treatment timeline, and what will be the treatment target. Because the blood pressure is very high, are we going to bring it down back to very normal level, or are we going to bring it down for a certain level? Because when the patient's blood pressure is very high, if you are going to drop it very abruptly, there can be problems with tissue perfusion. So therefore, in the guideline, it says that if you can bring down to less than 180 or 170, that will be really fine. So the treatment timeline, you have to bring down it up to that level within few hours time. And the choice of the drug, it will be intravenous, because no point in giving oral ones, because oral ones will take time to get absorbed and for their action. So you need a quick action. So therefore, our choice will be intravenous. So these are the available intravenous drugs in hypertensive emergencies. We have IV labetalol, IV GTN, IV hydralazine, and IV sodium nitroprusside. So these 4 drugs are available in most of the hospitals in Sri Lanka. So therefore, you will be able to deal with hypertensive emergencies. So first, we will discuss about the labetalol, which is combined alpha and beta adrenergic blocker. So the indications are acute hypertensive emergency with acute aortic dissection, because it will, in patients with aortic dissection, you will see hypertension as well as tachycardia. So if you give the beta blockers, you will get the desirable pulse rate. You need to maintain pulse rate around 60 to 70. So therefore, you can use beta blockers there. And if a patient is having neurological emergencies like acute stroke, so you need the acute quick action, so you can use IV labetalol, which is short acting as well. And maternal patient with preeclampsia and eclampsia, you can use IV labetalol. So the contraindications are, if your patient is having severe bradycardia, we may not be able to use it because it can further worsen the bradycardia. And if you suspect your patient is having pheochromocytoma, we should not use beta blockers initially. So therefore, that would be a contraindication. And when your patient is having acute left ventricular failure, once again, it will be a relative contraindication. So this IV bolus, we are going to give 50 milligram over 2 minutes. And we will be able to repeat in every 5 minutes. The maximum dose will be 200 milligrams. That means you can give 4 times. So if you are going to give IV infusion, it will be 1 to 2 milligram per minute dose. Then the next one is glycerol trinitrate. I hope that all of you have seen G10 infusions. Indications are hypertensive heart failure, which has got a prognostic benefit as well. So you can use IV GTN and patients with acute coronary syndrome. So if you suspect your patient to have raised intracranial pressure, this is a contraindication. Otherwise, you can use this drug. Dose, we can start with 5 mics and you can titrate until up to 200 microgram per minute. Depends on the blood pressure control. Third one is IV hydralazine. So it is a direct arterial vasodilator. Indication, so you have seen this is given freely in maternal wards, preeclampsia and eclampsia patients. So it is a contraindication to use if you suspect patient is having aortic dissection. So the hydralazine dose, IV 5 to 10 milligrams, you can repeat after 20 to 30 minutes. And when you are giving hydralazine, this hydralazine solution can get easily break due to the exposure to the sunlight. So therefore, you better avoid the direct sunlight exposure. So therefore, sometimes you may have seen this infusion is given with the covered saline bottles. So the final drug is sodium nitroprusside. So it is once again direct arterial and venous vasodilator. The indications for sodium nitroprusside is, you can use this one in any of the hypertensive emergencies. So the contraindications are if your patient is having raised intracranial pressure, you are not in a position to give it. And the other one is if a patient is having severe renal or liver dysfunction, you better avoid this drug and use the other drugs. So what about the treatment target? So the treatment targets depends on type of antihypertensive, type of hypertensive emergency, what you are having. So as I said, if it is a maternal patient, you have to bring down the blood pressures around 130s or 140s. But if it is a stroke patient and who is awaiting thrombolytic therapy, you have to bring down it below 180. You are not going to bring down it to 140, then there will be cerebral perfusion problems. If it is a myocardial infarction, once again, you can bring down to 180s, then you can start tenacteplase. So likewise, it will depend on the hypertensive emergency. So there are exceptions. The patients with aortic dissection, patients with pheochromocytoma crisis, pregnancy-associated ones. Right. So these are the goal time and BP targets. So in the first hour, reduce the mean arterial pressure by 25%. But if your patient is having aortic dissection, we are not targeting the 25%. We have to reduce it until the 130s or 140s. And if your patient is in a pheochromocytoma crisis, once again, you may have to reduce more than 25%. And if the patient is a pregnant one, once again, you have to bring down it. So in the next 2 to 6 hours, you will bring the diastole until up to 100 and systole until up to 160. And for the next 24 hours, you will maintain the this goal for 160s. For the 24 to 48 hours, you will come to the patient's normal blood pressure limits. So in hypertensive heart failure, for the statistics, 1/4 of the emergency department visits are for acute hypertension. And then they will get the hypertensive heart failures. So the drugs that we can use is to relieve the symptoms. We are using IV furosemide. So you can use IV furosemide 80 milligram, 40 milligram, 100 milligram. So if patient is in a acute massive heart failure, you can give a 120 milligram bolus and see how the patient responds. And then you may put the patient on even IV furosemide infusion as well. So then, because furosemide will give only the symptomatic benefit, you are going to start IVGTN or nitroprusside infusion to bring down the blood pressures. So when you are managing acute heart failure, you have to find out whether you are dealing with the ischemic heart failure or whether you are dealing with the infective heart failure. So what sort of a thing? So you have to cover all aspects. So apart from these drugs, when you are dealing with a patient with acute heart failure, don't forget to give aspirin, clopid, statins, and other oral antihypertensive drugs, which carries the prognostic benefit as well. So this is the summary. So in hypertensive emergencies, we are going to reduce in the first hour 25% blood pressure reduction is satisfactory, apart from the conditions like eclampsia, preeclampsia, aortic dissection, and the pheochromocytoma crisis. So then targeted gradual reduction needed in the next 24 hours. So then you will be achieving the normal blood pressure in day 1 to day 2. And you are going to avoid excess BP reduction. Nitroprusside is the agent of choice in most instances. So this is the management with the management of a patient with acute ischemic stroke. So if a patient is a good candidate for thrombolysis, once you bring down the blood pressure into 180, if patient does not have any contraindications, you can give alteplase. And if it is an intracerebral hemorrhage, you need to maintain a good cerebral perfusion pressure, and you are going to get the neurosurgeon's opinion. And if it is an aortic dissection, you will combine with the IV labetalol, and to control the pain, you will give IV morphine, and you are going to titrate the heart rate at around 60, and the blood pressure is less than 120. So to bring down the blood pressure until up to that level, you can use IVGTN or IV nitroprusside. So I hope that you know the preeclampsia management. So when a patient is fitting, of course, you have to give IV magnesium sulfate, and you are going to give IV antihypertensives as well. Then the treatment of choice will be you are going to liaise with the VOG to take the baby out. So these are the take-home messages. So if the blood pressure is above 180 by 120, you know that you are dealing with hypertension, accelerated hypertension, and take the history examination and see whether the patient has got target organ involvement. You are going to do the investigations. If all are there, you are going to admit the patient, IV antihypertensive therapy, and you will decide the drug of choice depends on the condition you are dealing with And first, our 25% of the reduction, next 24 hours, you are going to achieve the target. So these are the things that you should keep in your mind at the end of the day. So I'm sure that most of you will get these hypertensive emergencies, face these hypertensive emergencies, and you need to know this, how to manage, because you can save a lot of lives. Otherwise, all these patients will be ended up in further damage to their target organs. So thank you very much. And if you have any questions, I will be able to answer. There are 2 minutes more.
Yes, as Madam said, if you all have any questions, please unmute or use the chat box to answer. Ask your questions.
So Roshan, as there are no questions.
It seems like, Madam, yes.
Yes.
Yeah, thank you very much, Professor Manojit Patirage from University of Peradeniya on that detailed lecture on hypertensive emergency and acute heart failure. Thank you, Madam, once again. So,
Thank you very much, Roshan. Thank
thank you,
you.
Madam. So next up is snake bite and what by Dr. Priyamalekara, Janet KDU Atnas. Over to you, Madam.
1 minute, I think there's a problem with sharing. Give me a second, okay?
Okay, Madam.
It's not showing.
Madam, did you open the presentation?
Yes.
Right. Once you go to then once you open it, go to share screen.
So I think and my
Is it Neil Pattern, madam?
but I have been doing it from this way.
Neil Pattern, madam, presentation.
Desktop එක තමයි පෙන්නන්නේ මට.
Oh, enang presentation page. Presentation hari madam, it's coming. Yes.
නෑ මේ මේකනේ එන්නේ මගේ. මට මේකනේ share කරන්න ඕනේ. බලන්න
hari,
පෙන්නන්න
madam.
කියලා.
Right.
Can you see?
Yeah.
Snake bites?
Yes.
Ah, okay, that's fine.
Okay, madam. We can start, madam. Yes.
Okay, thank you. Good morning, everyone. So it's I was given a target to talk about snake bites. Now it's not only in periphery, even the Colombo we see snake bites, even Russell's viper bites here. There are 52 slides, but I will talk to you about the management. There are some slides about the identification and all. Those things actually I think you can go through, okay? So this is a kind of a case-based thing. So villager from Kantale brought a snake who was found in their garden. They are interested to identify the snake. Please identify the snake. So what is the snake? Okay. So out of these, So this is one of the difficult snake to identify. That is why we put that one. So that is wolf snake, okay? So don't mess up with the Russell's viper and start treating the patient. It is a wolf snake. Now, there are few slides about how to identify, which I will skip. So, sorry, this is with the not the Russells. You confuse with the crate bite because you can see both have same bands, color and things are different. When you have seen a snake, actually, unless you take it to the hand, you can't see these hexagonal vertebral scales and things. But, you know, there is a particular pictures in the wards, and even the villagers or your local people might be knowing better than you. So this is the one we might miss with the crate. So, but this is a cobra, and these are crate. This is saw-scale viper, Russell's viper, and the hump-nose viper. Okay. So how do we, now actually this is the real thing starts now. Initial assessment of a snake bite, weakening. So when the patient comes to you, first thing is, anyway, if patient is talking to you, you know the airway is all right. The breathing, if the weak cough is a kind of early sign, because they may go into respiratory paralysis. And then you may have to start ventilation with the ambu bag and keep the intubation trolley ready to intubate the patient, because most of the time trade rights are coming with the respiratory arrest. The Russell's viper things, and they also go into respiratory arrest because of the neurological thing, but bit late, not as great. So, and the circulation, you know, you may remember when you come to the viva, you always come and tell us ABCD. It's the same thing you see, and you can start some IV fluids until you sort out the rest of the things, and just see any evidence of envenoming, like bite marks or any neurological signs and all. So now, so this is a farmer from Polonnaruwa brought to the emergency department complaining of a swelling and pain in the right ankle after the snake bite. So he could not identify the snake. So in 15 minutes, patient developed vomiting and abdominal pain, hematuria, ptosis, and blurred vision. These are the actual scenarios you come across when you are an intern. So what is the first bedside investigation that you would perform? So it is 20-minute whole blood clotting time. Wherever you are, it is 20 minutes whole blood clotting time. But you can do the PT-INR if you have facilities available. But the first thing is first, because you do it yourself and you see it yourself. And it is more reliable than anything else. And then you send the creatinine, all these things, that is fine. But the initial first thing is the 20-minute whole blood clotting time, okay? You can do the ECG, you can do the creatinine, electrolyte, yes, that's fine. But first thing is first, it is a 20 minutes whole blood clotting time, don't forget it. So what we do is, some people use glass tubes, some people use glass bottles. Whatever the clean glass bottle, you put some blood and keep it. And if the blood flows, there is a coagulopathy. That means patient is envenomed. That is not clotted. If the blood does not flow, there is no coagulopathy and not envenomed. But that means that particular snake doesn't have hematological toxicity. So if you have any doubts, you repeat the test, and you are not going to wait for the 6 hours or something. If you are not sure, if you think like this is something wrong in this tube, you are not sure, just do it again. And then if you are if you think it's a Russell's viper because you are waiting to see this thing, so you repeat it an hour's time. If you are not sure who it is, so then you can just wait for the 6 hours and do. Usually that is the first test to remember, okay? So given the scenario about what is the most likely snake involved, what do you think? Who is the snake? Who is the culprit snake for that above scenario? Who coming with vomiting, that came and then develop hematuria and all? So it is Russell's viper. So you should, I think the people who are in Rajarata may have experienced this. So if you get a Russell's viper a day, that is the end of the whole week. So you have to deal with this patient for a whole day. That is that much nasty. So what is the next step in the management? What do? Do you go to administer antivenom 20 vials, tetanus toxoid, IV metronidazole, normal saline bolus, or are you going to catheterize the patient? What are you going to do? We have to do everything. But this is I'm asking the best of kind of thing. So now if you think this is Russell's viper, because patient had a ptosis, patient had coagulopathy now, so this is most likely, and snake is our Russell's viper. So you administer antivenom 20 vials, not 10 vials. It's a 20 vials, okay? If you are sure of the Russell's viper, we usually start with 20, not 10. So these are all guidelines for the management snake bite from the SLMA 2021. Anyone interested, you can go through the whole book. So usually the patient present to the with the snake bite, or if you are suspecting snake bite, the first stage is like everyone knows. Then you admit, reassure, and assess general condition. Resuscitate if necessary according to your ABCD. Assess for signs of envenomation like neurological. Then you do the whole blood clotting timer assessing. So try to identify the snake and you monitor the patient. Even you think it is a centipede bite, just monitor your patient, okay? So what can kill your patients? So respiratory arrest and hypoxic, and they can die. Then hypotension. So it can be the complications second to antivenom, and the hypertension can be due to snake venom itself or antivenom. Respiratory muscle paralysis is a major problem after cobra and crate bite, mainly crate bite. Still, you can get it after the Russell's viper bite as well, but mainly the crate, then cobra, then Russell's. And the hypovolemia is a result of vasodilatation due to this direct effect of cardiac toxic or venom-induced anaphylaxis. Those things these things are the things can kill your patient. If you keep this in mind, you can, within seconds, this will come to your mind, okay, whether this is that or that, and you can act fast. So these are the signs of envenomation. You can see the swelling, blistering, tissue necrosis. So the tissue necrosis mainly we see with our cobra. And the ptosis, you can see the ptosis and the myoglobinuria, and you can see this bleeding from the gum, the hematological manifestations. So what are the systemic effects? Like early non-specific features, you can see abdominal pain, especially in crate bites, nausea, vomiting, hypotension, or if you do the white cells, the full blood count, you can see polymyopathy of the leukocytosis. The specific features we see: neurotoxicity, spontaneous systemic bleeding, rhabdomyolysis with myoglobinuria, and coagulopathy. Okay. So don't ignore this abdominal pain. So the Russell's viper, usually we see the local swelling and they have neurotoxicity like ptosis, external ophthalmoplegia, and coagulopathy with a dark urine, prolonged clotting time in coagulable blood. And cobra, again, local swelling and tissue necrosis. He is the nastiest one to get the tissue necrosis. And the mainly neurotoxicity, ptosis, like external ophthalmoplegia, respiratory paralysis, limb paralysis. And they can have mild coagulopathy. Crate, no local effect. You might not be even able to find out where the bite mark is. And the neurotoxicity will be there. And no coagulopathy. And now this is a very nice graph. It's actually, I got it from the SLMA guideline. So just look at this. If the patient is having marked local signs, we'll see the pink pathway, yes. So if there are neurotoxic signs, yes, there are. And non-clotting blood, spontaneous systemic bleeding, then it's there. If patient's acute renal failure, yes, it is Russell's Viper. And patient is having marked swelling, neurotoxic signs, early distal necrosis, no clotting abnormality, usually cobra. But remember, cobra can have subtle coagulopathy, okay? And we'll come to the blue pathway. Marker local signs, we see there's no local sign, but there are neurotoxic signs. And then you ask, where do you get this bite? Patient bitten on land, sleeping on floor of a house. So it is crate bite. So if the patient got this in a lagoon or a sea or somewhere close to that, it is a sea snake bite. And now there's a marked swelling and non-clotting blood. Then you see neurotoxic signs, again, that is Russell's, okay? And there are no neurotoxic signs. And sorry, if there are neurotoxic signs, yes, Russell's Viper. If the non-clotting blood, then yes, you got neurotoxic signs. There are no neurotoxic. If the patient is having acute renal failure, yes, it is hump nose Viper, okay? But they might not go into acute renal failure as fast as Russell's Viper. And there's no acute renal failure, it is slow-scale Viper bite. This is just Google today, then if you can remember this, you can identify the snake without seeing even the snake. So what is the plan of action? So there's no signs of envenomation. You observe for 24 hours, no signs of systemic envenomation, no signs of systemic, you discharge. If the signs of envenomation, you do the ABS. Anyway, when starting signs of envenomation, if the local, you again observe, then go to the other path. If systemic, you do the ABS. So the monitoring, you monitor the patient's level of consciousness, pulse, blood pressure, respiratory rate, and tidal volume. If you don't have tidal volume, what you can do is ask patient the single breath count, and you can monitor with that. Temperature, urine output, full blood count. If you are suspicious of this is the Russell's Viper, better to catheterize the patient early than going into hematuria, and then will be a cumbersome procedure. So you avoid these things. No, however, patient's house, we don't give NSAIDs, including aspirin, and you stop even aspirin, whoever is CABG patient even, you avoid IM injection. We are no hurry to give tetanus toxoid, but we will not administer any other SERA like FFP or anything with AVS. No morphine, nothing, respiratory depressants, okay? So the antivenom, if there are systemic envenomation present, or local envenoming in cobra bite or extensive bites of other snakes, or severe abdominal pain in crate bite, there is an indication for antivenom therapy. So, and this is another one you have to remember. If you remember this one and the previous one, that is enough. So, immediately you start antivenom for the bites of Russell's, cobra, crate, slow-scaled. And however, you know that snake, you don't give anything for hump nose, green pit, or sea snake. And it is never too late to give antivenom provided the indications are present, okay? And we don't give antivenom for local envenomation except for the cobra bite. Usually we expect it to be more than two-thirds of the affected limb. And sometimes people come to you, they had a cobra bite 2 days before. Still, if it, imagine Russell's Viper or a cobra bite 2 days ago, especially the Russell's Viper, because the coagulopathy is persisting, and now you have whole blood clotting time is more, then you have to start the antivenom, even they come after 24 hours or 48 hours later. If there are any doubts, that is why there are hierarchy of people to ask. So start antivenom soon as possible. We can start with 100 to 200, that is 10 to 20. Russell's, sometimes we give 30, starting with 30 or a 20, okay? So endpoint of AVS is reversal of coagulopathy, reversal of whole blood clotting time. But you do this every 6 hours, and sometimes 3-4 times you have given 3-4 times antivenom. Then when you are doing on 5th or 6th time, it's still not clotting. But with that Russell's wiper bite, that patient can get coagulopathy due to the DIC. So your whole clotting time is not clotting because of the DIC. So you have to be careful about that. By the time that whole day has gone, you have enough time to do the blood picture, get others' opinion and all. Okay. So this is not gold standard, but we do pre-medication to reduce the reaction for antivenom. It's an adrenaline 0.25 subcut. This is actually recommended in SLMA guidelines, but we don't recommend this to young children or people with cardiovascular disease or strokes or hypertension. Can give the subcut before start. So now our patient, we started antivenom. Suddenly that particular patient developed rash, dry cough, fever, vomiting, difficult breathing. And what are we going to do now? What are we going to do now? So that patient developed anaphylaxis now. So the answer is IM adrenaline. So this is the anaphylaxis one. You may be having anaphylaxis module in other things, but I thought the completement's sake, this is whatever first thing is, first it's the adrenaline. Okay, nothing else. You can think about there's some things later. So again, this is about the adrenaline. But you have to remember, sometimes if patient is not responding, we might start IV adrenaline infusions. But it is mainly we do in the HDU setup or ICU setup. You have to always remember adrenaline is very hazardous thing to use. So what we have to do is you again restart. Give me 1 second. Sorry. I can't go back. Okay. This is about the anaphylaxis. And what we usually do is oh no, I can't go back. Okay. What I told is now anaphylaxis, you manage the anaphylaxis, still your patient is need antivenom. Imagine you have given half an hour, now half an hour is remaining. So you give rest of the thing for another half an hour after giving and settling this anaphylaxis. And once you, with some people, as I have already told, we might start them on IV and an infusion in the one arm, and the other arm we will give that antivenom because it is compulsory to give antivenom, otherwise patient won't get better. So this is another one, see. It's a typical history. A 35-year-old male from Anuradhapura, brought by a wife to the emergency department with difficulty breathing in the early hours of dawn. He was sleeping on the floor that night. The wife woke up and had noticed he was having labored breathing. So what is the most likely snake envenomation? So it is crate. So crate, don't want to worry about too much. That the very first one I told you about this SLMA guideline, the blue one, you have to, from the place where they come, where the patient is sleepy, you have to think about whether this is the crate bite or not. So we have given 10 antivenom and antivenom 10 vials given for the, because thinking it is crate, patient went to respiratory arrest and you intubated. So what is the next step? So these are the practical things you come across day to day. So to think about this, whether you are going to give another 10 vials of antivenom, IM adrenaline, supportive care and ventilation, tetanus toxoid, dialysis. So it is supportive care and ventilation because do not continue AVS administration for persistent neurotoxicity provided the coagulopathy has been reversed. I'm writing it in red because for the Russell's viper, they have persistent neurotoxicity, and if they usually have persistent coagulopathy. So in that case, you have to repeat. But if the crate bite or a cobra bite, if the persist after giving 10 vials of AVS, however neurotoxic person, you don't give other AVS, one is enough. Once the toxin bound to the whatever this ocular muscles or whatever, it takes time to go. So what you do is you observe your patient and conservatively manage in the ventilator or whatever until the patient gets up. Okay. This one. And now, a 66-year-old farmer presented to a general practitioner 5 hours after hump nose bite. His ankle had fang marks, urine output was good, he seemed directly stable. Which one of the following action you will take as a priority? In some hospitals, the HOs are in the A&E. So you have to do what I'm going to do. So because the hump nose viper bite, we have to monitor our patient. They might go into renal failure. That is why now hump nose also under the venomous snakes. So you have to admit to the nearest hospital for observation. Or if you are in the center where you can manage the patient, you keep the patient. And it's a local swelling or hemorrhagic blister. They can have coagulopathy, mild neurotoxicity, acute renal failure, but AVS is not indicated, okay? So they have found if the whole blood clotting time is high in the hump nose viper bite, those patients are the people who will go into the renal failure. So you have to very carefully monitor the patient, hydrate, input, output chart, look after the patient, but you are not going to do anything, any antivenom or anything. So it's aggressive management. You are looking after the patient. If they develop acute injury, it is you give dialysis. If they get the microangiopathy, we'll decide whether to go for a plasmapheresis or not. And if they develop coagulopathy, later on we might give FFP. Okay, the local tissue, it's easy to manage. So now this is the last one, I believe. It's a 66-year-old man was admitted of Russell's viper bite. So you treated with antivenom for 6 hours. Which of the following is an indication for repeat administration of antivenom? So it is whole blood clotting time. Nothing else. Okay. So these, I think I have covered all the things in the snake bite. These are the only things you have to know. Now, not only in Nikavalte, not only in Anuradhapura, even in this, Verahara area, suburbs in Colombo, we have Russell's viper, so anyone can come, and even the source scale viper is here because the sands are coming from Mana. So you have to, if you go through that pathway, you know, if you even don't see the snake, you can diagnose what particular snake bitten this particular man, and then you can act accordingly. Remember, even it's a centipede bite, if you have not seen it, we have to always start with whole blood clotting time, 20 minutes whole blood clotting time, and then we will go on. And for the crate bite, cobra bite, we usually give only 10 vials of antivenom, not more than, but after that it's a continuous supportive care. But for the Russell's viper bite, yes, you may continue every 6 hours or so after doing your whole blood clotting time. But once it is going on for 4 or 5 times, then the time you think, am I dealing with the DIC or same the antivenom, snake venom? So there, your seniors will come and help you. So that is the end of this. If you have any question, I'm happy to answer, even if you can put to the chat box or you can ask. I have 2 minutes. Thank you. It's 3 minutes.
Right. If you all have any questions, please unmute and ask, or use the chat box to ask. So we have about 2 minutes left.
Yes, I will. There are some questions, Roshan. The other person can start on time. There are 2 minutes. I will answer the chat box.
Yes, madam. Okay. We have another 2 minutes, so until then you can answer on the.
Okay. So what they have, as in the second case, Russell's, he had already developed neurotoxicity. So can he prescribe antivenom directly without doing whole blood clotting time? No, you have to always start with whole blood clotting time. Now that is the demand kind of thing. You can monitor your patient, but you start with 20 vials if you suspecting Russell's viper. Always. Sometimes we do start with 30. Okay, that's it.
Okay, thank you very much, madam, for that lecture. So, next up is lecture by Professor Chamala Dalugava, Approach to Shortness of Breath. Over to you, sir.
Right. Thank you, Roshan. Right. Okay. For the next 30 minutes, I'm going to discuss how to approach a patient with shortness of breath as a house officer. So this is going to be slightly different from what you have been doing so far as medical students, approaching to a patient with shortness of breath in your own case or in your clinical appointment. So what I thought was, to discuss all the aspects within 30 minutes is difficult. So I will present you a few case scenarios where what our house officers have done, and then you are welcome to just review these cases and think what went wrong so that we can rectify that and we can improve our practice, right? So moving to the first case, these are very authentic cases. So some of the photographs from the BHTs are also there. This is the house officer. The time is 9:30 p.m. So probably after a hectic day. And the patient is a 65-year-old male who is a heavy and active smoker. And when you open his clinic book, it says COPD in red. And when you turn the pages, there are multiple admissions with exacerbations. And then the house officer has documented worsening shortness of breath for 1 day. And these are her examination findings. The patient is dyspneic, pulse rate is 100, and blood pressure is 100/70, and a saturation of 84%. And you can see some sketches in the BHT where probably the lungs are drawn and it's an arrow shows some crepitations. Sorry. So the impression of the house officer was a COPD exacerbation, and this is exactly what her plan was. Chest X-ray, full blood count, CRP, serum electrolyte creatinine, and LFT, and documented ABGs not available at that time. And then she has given her initial management with nebulizations with salbutamol and ipravent, prednisolone, amoxiclav, oxygen via venturi 28%. So very correctly, she has thought this is a COPD exacerbation. You should not overcorrect the hypoxemia. So probably give some controlled oxygen just to maintain saturation between 88 to 92. Right. So when I saw this patient the following day, there are few important things missing in this clerking. So what can you think? Right. So we'll move to the next slide. So where is the history, right? So there's no proper history as such. And again, where is the examination? And then the house officer has ordered some liver function tests. So in this sort of patient, how it is going to help the management? And then she has ordered a chest X-ray. And the question was, did you chase it? Or did you at least hand it over to the other person who is taking over to chase the X-ray and have a look at? So these were the 4 questions I had to ask from that house officer. Right. So then we redid the whole thing. So this is the history. He's a heavy smoker, and he has been having this progressively worsening breathlessness over 5 to 6 years with cough and wheeze, and he's on inhalers. And for the same year, he had 3 hospital admissions with fever and increase in shortness of breath and increase in sputum. But today it's different. So today morning, patient had acutely worsening breathlessness with right-sided pleuritic chest pain. He clearly says, this is not like my usual things. No, this is different. I did not have any fever. I did not have any increased sputum production. It's just that I felt more and more breathless since morning, suddenly started with some pain in my right side, which gets worse when I take a breath in. Right. So this is the history. And then if you do a focused examination, I mean, as a house officer, we don't expect you to do your examination like in your short cases, all 4 systems completely. But in this sort of patient, after listening to the history, the focused examination, this is what I found. The patient was breathless at rest, tachypneic, and the trachea was clearly deviated to the left. And he had reduced chest expansion in the right side, and he was hyper-resonant in the right hemithorax. And there were no breath sounds in the right side. Right. So then we got her to got one of the minor staff person to print the chest X-ray, and this is it. This is it. So obviously you can see this is not exactly, but something similar to that. So patient is having a pneumothorax, right? So that is why I wanted to highlight initially that just as house officers, I know your days are going to be heavy, very busy, and but just don't get carried away with already diagnosed, existing diagnosis, right? Your clinic book might say he has COPD, and when you turn the pages, you might find 10, 15 admissions with COPD exacerbations, but this admission or the current admission may not be that. Therefore, as house officers, you need to think about that. So always have an open mind when you're seeing patients. And again, this is again the other important thing. Now we are in a financial crisis, and our hospital sometimes cannot afford all the investigations. And very shortly, once we get a set of reagents, we run out of it. Therefore, when you order investigations, you have to do it very intelligently, right? You should not be ordering a full set of investigations for every patient. So the same thing has happened to this one. So a patient was coming with breathlessness. Sometimes there might be some relevance, but at the time of admission, doing AST, ALT, liver functions, creatinine, they're not going to be very helpful in the initial management or diagnosis, right? So you have to be very particular when you're ordering investigations as well, right? So the take-home message in this case is, this is a pneumothorax. Luckily, patient survived for the overnight, and we were able to put an IC tube and survive the patient, but few important things were missed. Right? So it will not take a lot of time, just few seconds, asking exactly what happened, talking to the patient, and doing a focused examination would have given you the diagnosis, right? A very obvious diagnosis, but it was overlooked, thinking this could be another exacerbation of COPD. Right. So moving to the case number 2, this is again the house officer, 3:50 in the afternoon. So probably waiting for the other house officer to take over the UEN duties. And it's a stat admission, right? So OPD note, all what it says is a patient with shortness of breath, and she has chest pain. And so MOPD has queried MI with heart failure. And the history, it's a 57-year-old lady with diabetes and hypertension, person in shortness of breath for 3 days with orthopnea and paroxysmal nocturnal dyspnea. And she was complaining of on and off chest pain, right? So this was the note taken from the house officer, right? Right, so house officer has done a short examination. So she has found there are a few crackles in the lungs. She has got ankle edema, and the blood pressure was 150/90, and patient was tachycardic. So these were the positive findings in her examination in the initial clerking. Right. And then she has ordered the investigations, ordered the full blood count, blood urea, electrolyte, creatinine, and the troponin, because the patient has some on and off chest pain and some features suggestive of heart failure. But that time, hospital was not doing troponin. The reagents were out. So the troponin was sent to a private lab, and the other investigations were sent to hospital lab. And the ECG was done, and obviously you can see there are some changes, right? There are some T inversions that you can see in the ECG, right? Mainly in lead 2, 3, AVF, and in lateral leads. Right, so the family brings the troponin report after 2-3 hours because it is from the private sector. So they have brought the troponin, and the house officer has made the diagnosis of an acute coronary syndrome because troponin was 56, where the upper limit is 17. Right, so the ACS patient was given aspirin, clobid, statin, enoxaparin, and some furosemide because he had some crackers, and was started on losartan as well. So this patient, in the night round, we say night round, patient was more breathless and she was looking fairly unwell. So the patient is already received dual antiplatelets, statin and enoxaparin as well. And then the nurses have attached the previous day. These are not ideal settings, I would say. These are practices that need to be severely discouraged, but these things can happen in your ward as well. So the nurses have attached the previous day sent investigations to the hospital lab, and to see the hemoglobin is 4.5. The creatinine is 98, there's a mild transaminitis, and otherwise the investigations are normal, right? So what went wrong is, here again, a good history was not taken from the patient. The examination was not focused into the problem, and importantly, if you send some investigations as house officers, you should be accountable that you chase the investigations and to see what went wrong in those, right? So you can't just order the investigations and wait the nurses to attach the investigations the next day morning, because similar thing can happen to your patient as well. Right, so then we read the case again. We started from the beginning. Okay, what the history, good old history. So to see this lady is having bilateral osteoarthritis, and she was taking over-the-counter medications, over-the-counter diclofenac for several months. And for 1 week, she has been having dyspepsia, some dyspeptic symptoms, and tarry black stools. And then when you examine, one crucial thing in this patient was missed. This is a patient who has come with shortness of breath, who has features of heart failure, but the pallor was missed. To see the patient was paper white, conjunctiva white, and she was having severe pallor, which of course confirmed by the investigations with a hemoglobin of 4.5. Right, so before talking about approaching a patient with shortness of breath, these are the take-home messages. Don't always get carried away with the existing diagnosis, right? Or what your clinic book tells. It might tell heart failure, it might tell ejection fraction less than 30%, COPD, ILD, bronchial asthma. No, always have a fresh mind, have an open mind, and take a targeted history and a focused examination, right? So you need to use your common sense. And the other thing is, you have to be accountable and responsible. So as house officers, you can't expect somebody else to chase the investigation. I mean, you can send some minor staff, you can delegate the duty to someone to bring the investigations, but you are the overall person who is accountable to make sure that all the requested investigations have been sent and have been chased and have been looked at and actioned on them, right? So with that, we will go to the talk proper. Right. So if a patient comes with shortness of breath, how you would proceed as a house officer? So the initial assessment is very important. So, right, you need to see whether the patient's airway is patent. I mean, patient may be having an impending respiratory arrest. So always assess the airway patency. The simplest thing that you could do is you can talk to the patient. And if the patient tells his name and the address, yes, at this time his airway is patent, and listen to his lungs. Observe the breathing pattern, right? See whether he's using accessory muscles, and then always in patients with shortness of breath, monitor the cardiac rhythm, measure the vital signs and the pulse oximetry. So once you make sure your patient is stable, right? He's not going to arrest within the next 5 minutes while you are taking the history. Yes, you are good to go and take the history and then do a detailed examination, right? Okay, so these are the patients that you need to see stat. Right? Maybe after you have worked on with the consultant, you may be having a heap of BHTs waiting to be clocked. But always have a glance at the patients, take the DHGs to your hand, look at who are those patients waiting to be clogged. And if the patient is hypotensive, who has altered mental status, who has low saturations, or abnormal rhythms, yes, patient is unstable. A patient who is sitting on a chair but having a very abnormal breathing effort, right, who makes a noise when he takes a breath in, who has a stridor, yes, you can't wait, you need to see him. And then again, patients who have the features of unilateral tracheal, I mean, this you need to examine, but any tracheal deviation, hypotension, unilateral breath sounds, yes, you need to attend immediately. And any patient who has severe tachypnea, respiratory rate of more than 40, cyanosis, low oxygen saturation, I mean, these are the patients who are unstable, who will not survive until you clock next couple of patients, or until you have your lunch and come back, right? You need to see them immediately. And always, as house officers, if you see this sort of unstable patients, you have a team, right? So until you get your full registration, you're always working with a team of consultants. You will have either registrars or senior house officers, and call for help, right? So don't try to manage this sort of unstable patients on your own. And then you look at their airway, breathing, and circulation. But if your patient is stable, yes, then you need to sit and take a history. And this history is not that what you take in your 40 minutes as a student in your final loan case. This is a more or less a focused history on symptoms, but you need to ask some crucial questions, right? If the patient is coming with breathlessness, what is the onset, whether it's an acute, subacute, chronic, and how it progressed? Was it like over minutes, hours, days, weeks, months? So in the first patient, you see, if you ask, how did this happen? The patient clearly says, this happened within minutes and I suddenly felt breathless and I had a pain in my right side. So that tells something is acute. And then in any shortness of breath patient, good days and bad days, right? So your COPD patients will have most of the time bad days. Every day the patient is having some degree of breathlessness. But if your patient is an asthmatic, might be perfectly fine for a week, and then with some triggers, he's having a bad day and the associated symptoms. Right. And then the breathlessness, right? So it could be due to anything, right? So it could be due to a problem with the lungs, it could be a problem with the heart, it could be a problem with your blood pump, and sometimes the kidney, brain, or even liver problems can present with breathlessness. So ask few symptoms in your systematic inquiry just to make sure that you are not missing anything, right? If the patient is complaining of yellowish sputum, cough, and wheeze, it points more towards the lung. But if the patient complains of mainly orthopnea, exertional angina, palpitations, right, probably something to do with the heart. And then the blood and clots, right? If the patient is having faintishness and palpitations, and just like our second patient who was having dyspeptic symptoms with melena, might point towards, okay, could be due to anemia. And then sometimes pump failures, which are not very common, but patients with, say, myasthenia, or patients who have some other neurological features, it could be due to a pump failure. So urine output is very important, right? If you get a patient who is breathless and you see the patient is a bit overloaded, and if he has not passed urine for last 48 hours, okay, the pathology may be in the kidney, but not in the heart or lungs. And sometimes, as a diagnosis of exclusion, this breathlessness may be a panic attack. So that also you need to keep in your mind. So the general examination, any patient with shortness of breath, talk to the patient. Then you know the airway is patent, and get an idea about what is baseline like. And then you have to have an idea about the degree of respiratory distress. And always check whether the patient is pale or not. This is something that we often miss. And the cyanosis, pursely breathing, ankle edema, those are some basic things that you can just look at the patient at a glance. You should be able to pick up these things. And then any shortness of breath, any patient with shortness of breath, examining lungs is very important. So look at the trachea, right? So in the first patient, even at the foot end of the bed, the trachea was to the left. So look at the trachea and then see, percuss and auscultate the lungs, right? So you don't have to do it as a short case, but You have to just to see whether your findings are unilateral or bilateral, right? So if it is unilateral, see whether there's stony dullness with absent breath sounds. Right? That's it. You make a diagnosis of effusion. But you find the lungs is dull, the lower bass is dull, but you hear bronchial breathing. It's a consolidation. And just like in our first patient, lung is hyper-resonant, but you can't hear any breath sounds. It's a pneumothorax. So it's a very simple algorithm where you look at the trachea, you percuss auscultate, see whether there are unilateral findings or bilateral findings. And then based on that, you can make a clinical diagnosis of what you are seeing. And if the lungs are bilateral, if you get completely clear lungs, think about anemia, right? Particularly in patients with normal saturation. In anemic patients, saturations usually don't drop. Or it could be a panic attack. You get a patient with clear lungs, with tachypneic, dyspneic, but low saturation. Think about a clot. And if you get bilateral findings, if it is V's, could be COPD, asthma, heart failure. Crackers, if it is fine crackers, could be heart failure or interstitial lung disease. You ask the patient to cough and the crackers disappear. Could be heart failure. And if the crackers remain the same, could be interstitial lung disease. And cause crackers, it could be due to bronchiectasis, pneumonia, something like that. So, I mean, this is not a very standard one, but just a very crude guide for a busy house officer when he's clerking to do a very focused, very targeted examination to see what's the problem with your patient. Right, and then examine the heart, right? So the reason for your patient's shortness of breath may be in the heart. So you check the pulse rate, rhythm, volume, and see whether JVP is raised or not, see where the apex is, and listen to the heart. You can hear the heart sounds clearly, good, but if you can't hear them, it may not be your problem or your stethoscope, but patient may be having a pericardial effusion. And look for murmurs, and sometimes you can hear galloping, right? So again, it will give us clues why the patient is breathless. And then depending on your history and examination, you decide what basic investigations you need to request. And make sure that you will not request all the examinations or all the investigations under the sun for a patient, thinking that one might become positive. So very targeted investigations, right? A full blood count is important. If you find the patient is pale, or if you think this patient could be having a pneumonia, the full blood count might give us useful clues. And the ECG is very important, right? So always do the ECG because it might tell us the diagnosis. So this is a ECG of a patient who has come with breathlessness, and the house officer found it difficult to auscultate the heart because heart sounds were not clear. So he has done an ECG, and what you see is small complexes, and you can see the electrical alterance. Yes, the alteration between the size of the QRS complex. So this patient was having a pericardial effusion, right? So then you can request a chest X-ray, right? So you can have a patient with, the slide is a bit distorted, but yes, you can see could be having a effusion, could be a pneumonia, could be a pneumothorax, or sometimes a chest X-ray may be absolutely clear in a patient with a pulmonary embolism. Right. Okay. So I think that brings to the end of my brief presentation. And these scenarios, I think we will not have time to discuss. So out of what I have discussed, have you got any questions? I think I've got 8 minutes more. Yes, you can. Welcome to ask any question if you have. Right. Okay. So in the absence of any questions, we just to sum up, right? So I didn't do a very comprehensive sort of long lecture on different causes and different sort of management strategies in patients with breathlessness. I just wanted to show that as house officers, you are busy, you have a lot of work, patients are waiting to get their discharges, but still, if you get this sort of a patient, this may be applicable for anything, like not only shortness of breath, maybe abdominal pain, maybe leg swelling. So always have an open mind, take some time, think smartly, and do a very focused, targeted history and examination and do the relevant investigations. Right. Okay. Thank you very much. And I can think you can get a 5 minutes break before the next lecture. Thank you.
Thank you very much, sir. That was Professor Dalugama on that comprehensive lecture. Thank you, sir, once again. So, next lecture is by Dr. Krisantha Jayasekara, consultant physician at TH Karapitiya. The topic is fluid therapy. Right. So I will join shortly.
Prashant? Prashant? Prashant, can you hear me? Prashant?
Yes, sir. I've given the introduction. You can start straight away, sir.
Thank you. Let me share the screen. Right. Okay. Can you see my slides, Prashant?
Yes, sir. Full screen, and we can hear you.
Sorry, just we were a couple of minutes. Just finished the ward rounds. Okay, welcome. So good afternoon, I suppose. My topic is on basics of fluid therapy. Now, I'll start with a case scenario. A 54-year-old hypertensive male admitted with 4 days history of headache, body aches, nausea, and poor oral intake. On admission, he has signs of mild dehydration. He was afebrile. He was mildly tachycardic. Blood pressure was 110/75, and his other exam, otherwise he was normal, and he weighed 60 kilos. He had his routine blood test done on admission. So this is a typical admission that you would get into any sort of a ward when you become a house officer, right? So first thing, would you prescribe intravenous fluids is the first question. Second question, what is the fluid and what rate and what is the duration of fluid therapy? Third thing, how would you assess the response and further fluid needs after you give the initial fluids? So this would be our initial case, and based on this, we will proceed to our next slide. Now, intravenous fluid therapy, decision to start intravenous fluid should always be justified, right? And deciding on the optimal amount, composition, and rate of administration of IV fluids is not easy, and it's inherently difficult. The other thing is now most of these decisions are taken by junior-most members of the team as well as the nurses, and they have limited training and competence in handling the fluids. So there is plenty of evidence that there is mismanagement of intravenous fluid use in wards. So this will sometimes lead to adverse outcomes, increased morbidity, prolonged hospital stay, and adding to increased cost to the health budget. Now, there are a few principles involved in fluid prescribing. First thing is we need to know physiology of fluid and electrolyte balance in health, which I will elaborate, that we have learned during our medical school career. Second thing, what happens to this during a pathological process. Third, clinical approaches to assessing IV fluid needs. Fourth would be the properties of each and every IV fluids. Now, if you look at the fluid distribution in a healthy adult, if in a male, 40% of your body composition is in solids and 60% is in fluids. Out of that, 2/3 is intracellular, is only 1/3 is extracellular. So from this this is where we now, out of that extracellular fluid, again 80% is interstitial and 20% is in plasma. So we give fluids to the plasma component, and then there is fluid distribution to the interstitium and the rest of the intracellular compartments as well. So this is what is normal physiological fluid distribution in body. This is what happens to electrolytes in physiological status. You have, cations and anions. You have in the, main extracellular cation is sodium, whereas main intracellular cation is potassium. When you come to the anions, main extracellular intracellular anion is phosphate, whereas it's chloride in interstitial and plasma. So this is a normal electrolyte changes and chloride of 103. Whereas when you take the intracellular fluids, it's mainly potassium, which is very high in comparison to plasma. Now, so how do you balance this body's intake and body's fluid loss? So the body gets fluids, either water or from metabolism, and the body loses fluids with feces, sweat, and urine. So now these things can change during disease status. Now, for instance, if somebody is polyuric, they will have more fluid losses as well. If they have got diarrhea, there will be plenty of fluid losses. So this can be disturbed during pathological state. Now, insensible losses account for about 10 to 15 ml per kg and about 600 to 900 in a healthy male, right? So now there are certain factors that will change the insensible loss. Now, for instance, somebody is febrile, will be losing 2.5 ml per kg per day for each degree rise of temperature in centigrades, right? Burns and other desquamating skin lesions will cause more losses. Similarly, diarrheal illnesses will cause about 150 to 200. So if somebody is having about 10 episodes of diarrhea, they will be losing about 2 liters of fluid. Insensible, these become insensible losses. So you need to compensate for that when you replace fluids, right? So you need to keep an eye on the insensible losses, which might not be accounted to normal fluid status if you do not take them into account. Now, pathological effects of illness on fluid balance. So now illness and injury alter fluid and electrolyte balance in many ways. Now, there may be a body's ability to handle fluid and electrolytes may change, right? There is non-specific response to stress, and there may be restricted food or water intake, and there may be changes in insensible losses, which I have mentioned, due to illness or environment, right? So there are few factors that we use to approach the assessing IV fluid needs, right? First thing is, what is my patient's current fluid and electrolyte status? Number 2, what are my patient's routine maintenance needs for fluid and electrolytes? Third thing, can my patient meet fluid and electrolyte needs by the oral or enteral route, or does this patient need intravenous? Fourthly, does my patient need IV fluid resuscitation? And does my patient have existing fluid and electrolyte deficits or abnormal ongoing losses? And does my patient have other comorbidities which will be aggravated by rapid intravenous fluid administration, right? So those are the factors that will decide your fluid administration. Now there are many properties of intravenous fluids that we use that we need to know. There are 5 basic things that we use. One commonly is, which is isotonic saline, or we call it normal saline. Then there are balanced crystalloid solutions. The plasmalite is the ideal, but we don't have that. We use Hartmann's. Then there is glucose and glucose saline. Glucose saline is more used in pediatric practice. Then there are synthetic colloids, right? And then there are albumin solutions that we use. So these are the intravenous fluids that we use, and we need to know their composition, roughly about their composition as well. So if you look at the normal saline, now it has its sodium content is more or less similar to plasma, but it has a high chloride concentration. So you have to be mindful about the chloride concentration, right? And then Ringer's lactate has more or less similar chloride and sodium. So that is why they are called, balanced crystalloids. And plasmalite is more or less the same to plasma, right? So these are the crystalloids that we use. And if you take the colloids also, some of the colloids contain a lot of chloride. So you need to be mindful about the chloride administration when you give fluids, especially when you give a lot of colloids. Now, there are 4 R's involved that you need to know in fluid administration. One, whether your patient needs resuscitation, right? Somebody whose blood pressure is low, fluid volume is low, you would resuscitate with intravenous fluid. Or somebody who is coming with doesn't need resuscitation but would need maintenance because he can't take orally, intravenous routine maintenance. For somebody who is losing fluids for some reason, say something like vomiting, diarrhea, you replace them, but their blood pressure is stable. Or there is redistribution of fluids. Sometimes what happens in somebody like CLCD, there would be tense ascites, and there is redistribution of intravascular volume, but you need to replace the intravascular component with fluid. So these are the 4 things, and in addition to that, the other thing is reassessment. After each and every management, you need to reassess the patient, whether the patient needs further resuscitation, whether the patient needs further routine maintenance, further replacement, or something else. Likewise, so reassessment is there after each and every category of fluid administration. So we'll go back to our patient again. This is a 54-year-old. So would you prescribe intravenous fluids? What is the fluid? And how would you assess? Now, these patients, the category should be routine maintenance, because if you go back to these patients, patient is mildly dehydrated, patient's blood pressure is stable, does not need resuscitation, he is unable to take orally, he has lost a little bit of blood fluids due to poor oral intake, and then we would like to give him some routine maintenance. So when you subjects for routine maintenance, there are a few considerations to make. One thing is the patient is unable to take orally, so you need to replace fluid and electrolytes equally, right? So then whether you can give fluids liberally, because whether there is any contraindications to give fluids, somebody who's got congestive cardiac failure or somebody who's got a acute renal failure, you will be a little reluctant to give too much of fluids, right? So your prescription of fluid for a patient for maintenance should contain about 25 to 30 ml per kg per day. So if it is a 50 kilo one, it should be roughly around 1250 to 1500 ml of fluid. Rate 1 to 2 ml per kg. So if it is a 50 kilo, 100 to 50 to 100 ml per kg per hour. Sorry, for a 50 kilo, it should be 150 to 100 per hour. And then electrolytes you replace with 1 millimoles of per kilogram per day. So it's a 50 millimoles of potassium, sodium, and chloride. And you saw that sometimes when you give a normal saline or isotonic saline, the chloride content is going to be higher than what is needed, right? And if you want to give glucose, so approximately 50 to 100 grams per day of glucose to limit starvation ketosis. So you might need to give a bit of dextrose as well, because it contains glucose, right? Now, for patients who are obese, suggest IV fluids. Now, for patients who's got congestive cardiac failure, you might not give 25 to 30. you might give them around 20 to 25 ml per kg per day. So your fluid total volume has to be reduced if a patient has you have any concerns about fluid overload for or a patient, right? So now, so you are 60 kilos. So your fluid is about 1,500 to 1,500, 1,800. So your sodium potassium chloride 60 ml and your glucose is 50 to 100 grams. So how would you decide the amount of total fluid that he needs, right? If you are going to give them if you are not going to give them adequate electrolytes, or fluids, the patient would get dehydrated, and then what you could do is you could, for this patient, to give your adequate amount of total. So you can give about 1 liter of isotonic saline and 1 liter of dextrose, which will contain about the needed glucose load as well, if the patient is not taking any carbohydrates orally. So if the patient is taking orally, you could come down on the intravenous and replace what is left or what he can't take orally of the allotted fluid for the 24-hour period, right? So we will be moving on to case scenario 2. Now, same case scenario, we will be continuing on day 2. He remains afebrile, is hemodynamically stable, his hydration is normal. Now he is able to take food orally. So what should we do now? Do you need to continue IV fluids? Or if so, what type, volume, rate? So this is the next question. So this is the reassessment, routine maintenance and reassessment, right? Reassessment of further fluid requirements. So first thing is to clinically look at the patient, right? Then examine for vitals, including pulse, blood pressure, and the other important vitals, including urine output, right? Then make count of the insensible losses, whether the patient is having any diarrheal illness, so then you need to look for any diarrheal episodes. Serial measurement of body weight. Sometimes in some patients who are, especially who are fluid overloaded, we will go by the daily body weight as well. If there's an increase is there a weight gain, we have to be a little careful, right? So then you might also do few investigations to see whether where the electrolytes are well balanced. Sometimes you need to check the urea, creatinine, and electrolytes, and chloride as well if available, because we might have given a little too much of chloride, which might cause hypochloremic acidosis, right? So you need to be, so before you prescribe further fluids, now these are the components of the reassessment, right? Now, we will move on to case scenario 2. A 54-year-old lady with poorly controlled diabetes
I think sir got disconnected. He will join shortly.
Prashant? Prashant?
Yes, sir.
Sorry, I didn't know that I got disconnected.
Yeah, I tried to.
Yeah, okay. But I will quickly take 5 minutes and I will just finish
Yeah,
it.
I spoke to Professor Tama Vijay, so he's okay with it, sir. Yeah. So share කරන්න මේ pin එක.
Right. This is problem with this. Take sages.
Presentation එක දාන්න ඕක නෙමෙයි sir. මැද හරි sir අතර උනේ. අයියෝ. unmute කරන්න වෙයි.
Yeah. Can you see my slides now?
Yes, I can see.
Sorry, sir. Yeah, okay. Now, right, okay, so we'll I will quickly finish, move on to case 3. This is a 54-year-old known patient with child B cirrhosis, diabetes, who present with low-grade fever, abdominal pain, loose stools, altered level of consciousness, and poor oral intake. On examination, he weighs 84 kilograms. He's icteric. He's got generalized edema. His GCS is 14, as he got moderate ascites, and his he's got thrombocytopenia. His creatinine is high. His sodium is low. Albumin is low. So there are plenty of problems. Now, this sort of a patient is very commonly that we see, complex patients. And what is the fluid management? So it might be the first contact, might be the intern house officer, and then this is a patient who's got already edematous, has got some diarrhea. So now this patient would either need a replacement or redistribution. Replacement is where you might need to replace the diarrhea. He's losing fluid due to diarrhea, but you have to be careful because he's already edematous. And then redistribution, because some of the fluid that is in his intravascular compartment has actually been shifted to interstitial spaces. So you need to be mindful of that as well, right? So if you list the problems of these patients, right? So child B cirrhosis, he's got fever, diarrhea, altered level of consciousness, and he's got generalized edema, jaundice, so plenty of problems. So first, would you start IV fluids? Second problem, what type, what rate? And then now intravenous fluid replacement. For replacement is where you replace somebody's fluid that has been lost, but you have to be mindful of the fluid status of the overall fluid state of the patient. So this patient has got edema, but he's got diarrhea. So you need to replace the amount of fluid that is lost through diarrhea. Then you need to be mindful about the other factors, because this patient, some of the fluid is has been redistributed to the interstitial spaces, or what we call third spaces of the peritoneal cavity. So you have to be mindful about that, and then giving fluids will be a little harmful on some of these patients, right? So deciding on fluid for this patient, now calculate the ideal body weight of this patient, check the fluid status. This patient is actually fluid overloaded. Calculate daily requirement of fluid and electrolytes. So patient would need, about 1.5 to 2 liters of fluids. And then electrolytes, this patient is hyponatremic. Identify existing electrolyte abnormalities and take account of ongoing losses. So we know with each diarrheal illness, you might be losing about 200 ml of fluid. So you need to be mindful about that as well. And you need to maintain a very good meticulous input-output chart and a daily weight chart as well, which are very important as a house officer to decide on the fluid balance of a patient. And then you can prescribe crystalloids for the losses, so what we call replacements. And then you can use colloids for replacement as well as redistribution, because that will try to get the intravascular compartment, more fluids into the intravascular compartment. And then you need to reassess these patients. These are the patients who are really, you have to be very, very careful and always get senior help when you deal with fluid, because that can increase mortality if you give inadvertent fluids for these patients. So just apologize for the technical fault that we had. And just to conclude, now understand the basics of fluid and electrolyte balances in patients with normal physiology and during illness, and know the composition of commonly used fluids that commonly used. That is, either is it sometimes it would be crystalloids, it would be colloids, and assess the risk and benefits of benefits and harms of IV fluid administration. Some people, you might be causing harm by giving too much of IV fluids. And remember the 5 R's in fluid administration: resuscitation, routine maintenance, replacement, redistribution. And after each and every step, you need to reassess the patients, and whether the patient still needs resuscitation, if the patient still needs routine maintenance for somebody who is now getting better, or replacement who is still losing some diarrhea. So redistribution for patients, and then ensure medical nursing staff involved in fluid prescribing and administration trained in these principles of fluid administration. So thank you very much. And just apologize, Roshan and the rest and from Namal for taking few minutes of your presentation as well. Thank you very much.
Thank you very much, sir. Technical issues happens most of the time. So thank you once again. That was Dr. Krishant Jayasekara, consultant physician at Teaching Hospital, Karapiti. So we come to the last lecture for the day. It's by Professor Namal Vijayasinghe, Essence in Cardiology. Over to you, sir.
Good afternoon, everyone. I'm trying to get my slides sorted. I hope you can. Yeah, can you only hear me?
Yes, and slides are moving, sir.
Yeah, okay, and you can see my slides as well, right?
Yes, right, sir.
Okay, so the final talk for today is on basic ECG interpretation. What I'm going to discuss is what we teach the medical students, because we believe that some of the ECG abnormalities are very important for them to detect during their internship as interns, because if they miss them, the patients may be in a serious condition or in jeopardy until the seniors do the ward downs and see the patient. So that is the whole idea. But in the meantime, I will try to touch some basic ECG abnormalities that the interns should be able to detect. So as I always say, like ECG is like life. There has to be up and downs in life, like the ECG waves. If it is a straight line, it is like you are dead. You are not like a living person. Now, a basic ECG complex is like this, and we have learned this in the second MBBS level. As you all know, you should be able to identify the basic waves in the ECG. The P wave that represents the atrial depolarization, QRX complex that represent the ventricular depolarization, and also the T wave that represent the ventricular repolarization. And the basic waves and the intervals you need to know, like the PR interval. Some people say PQ interval, that is from the beginning of the P wave to the beginning of Q wave. And also the QRS width is important to determine whether the QRS complex has widened or not. And also the other important interval is the QT interval and also the RR interval. So in this slide, you can see what are the important waveforms and the intervals that we would like you to know. The 12-lead ECG comprises of 6 limb leads and 6 chest leads. The chest leads are also called the precordial leads, and they vary from V1 to V6. And there are 3 limb leads we attach, and together with earth on the right lower limb. The limb leads include left upper limb, right upper limb, and the left lower limb. And using these leads, we generate 6 leads. Some are called the unipolar leads, and others are called the bipolar leads. Your L1, L2, L3 are bipolar leads. For example, L1 is when you use the left upper limb and the left right upper limb leads and generate a wave pattern. It's called L1. And L2 is when you have left upper limb and right upper limb and right upper limb and left lower limb is L2. Likewise, you generate L2, L1, L2, and L3. Instead of combining 2 leads, you can use the wave pattern from 1 lead and augment the lead, the electrical activity, and it is called augmented limb leads. They are the AVR, AVL, and AVF. So, as intern house officers, you all need to know how to do an ECG by yourself. So, at this point, if you don't know, go to somewhere, go to your own prof unit or to the hospital that you trained or any other place and learn how to do them. And we teach them in the second MBBS level as well as throughout the clinical training, because some of the places that you might end up doing internship, you will have to do the ECGs at least during off hours. No hospital in Sri Lanka in the public sector will have ECG technicians working during off hours. So either the nurses have to do it or you have to do it in an emergency. Say you are working in a surgery ward and someone post-op having chest pain or palpitation, you have to do a 12-lead ECG. And when you call the medical team, they'll ask, do a ECG, we will come. So you need to do. So that is first lesson from this talk is for you, A, to identify the basic wave patterns and the intervals. Secondly, you should be able to do ECG by yourself. But when you start doing the internship, look at the ECG machine that you have in your ward and play with it and know the buttons. And because the time that you have to do a ECG will be in an emergency. So at that time, you can't learn the machine. So you have to first learn the machine, know how to do a basic ECG, where to attach the leads and so on. And in an emergency, if there's no one to do it, you should be able to do it. Don't ever call the consultant and say, sir or madam, there is no person to do a ECG here. They will scold you. So that is the first thing that you need to learn from today. Now, before you start reading ECG, I want you to pay attention to few things. Firstly, the patient identity, because it is very common that the ECG is filed in wrong BHTs. And also even in the private sector also, when we see patients outside or in the clinic, it is very common to bring somebody else's ECG with them. What I face normally is I see the ECG in the file, but it is not his ECG, wife's ECG, because for them all the reports are same. So it is just asking, you must be Mr. Pereira or something like that. Just to check the name and the time of the ECG, because it also has a sequential order. First ECG and what happened 15 minutes later or half an hour later. So you need to pay attention to the patient's identity. Read the correct person's ECG. Secondly, the lead position. I'm not going to go to detail, but learn how to identify lead malposition. The commonest lead malposition is having limb lead reversal in the left and right upper limbs. So in the place of left upper limb lead attachment, they attach the right upper limb lead, and for the right upper limb place, they attach the left upper limb lead. You can easily identify that by looking at the P wave of the L1. So I normally start reading the ECG by looking at the P wave of the L1, because I quickly identify the limb lead reversal. I mean, there are other reasons, like in dextrocardia, you also get a P wave inversion or negative P wave in L1. But common situation is that but there are several other limb lead reversals. It can happen in any order. You can have the left and right, upper limb and lower limb reversal. And I have seen patients, for example, without attaching V1 in the right side of the chest, they attach in the right place, but V1 is in the place of V6, and V5 is in V2 is in the place of V5. Likewise, they completely reverse sometimes by a mistake. So you need to pay attention to that. Paper speed and amplification. The usual speed that we all do is 25 millimeters per second, but sometimes by a mistake or sometimes by purposefully, they change the paper speed, as well as the electric voltage or the signal amplification of the recorded complex. Therefore, you might get distracted, or you think that the patient is having bradycardia if you miss the paper speed. And also the artifacts. Artifacts are common. There are muscle tremors, there are motion artifacts. So see whether rather than just jumping to a diagnosis, whether these abnormalities you see on the ECG are due to artifacts. So these are the things that before reading ECG that you must pay attention to: the patient identity, the lead positioning, paper speed and the amplification, as well as the artifacts. Now, this is an example. If you look at there are two ECGs shown here. in the upper panel, the correct paper speed, 25 millimeters per, and in the bottom ECGs are 50 millimeters per second. So if you look at the upper ones, we can, because we have trained our eyes to identify arrhythmias. In the left-hand side of your screen, it is the atrial flutter with 2 to 1 block. But if you look at the bottom ECG, it's very difficult because it doesn't look like atrial flutter. And similarly, atrial fibrillation on the other panel, and you will miscalculate the the heart rate also if you don't know what the paper speed is. Therefore, please pay attention to the paper speed. If you look at this ECG, this is the usual signal amplification or the voltage. The usual ECGs, it is 1 millivolt per 1 millimeter. So this is the same. What I want is, if you look at the ECG and look at the small box at the end of the ECG on the right hand side corner of the screen, the small box indicate what is the signal amplification is. So if it is 10 millimeters, that is 1 millivolt per 1 millimeter. If it is half, that they have half the signal amplification. For an ECG like this, because this is a A4 size ECG, and you look at the V4 lead, it goes above the ECG paper onto that white area. But if you take a tape, you won't be able to do that because it's only a paper of certain height. So what lot of experienced ECG cardiographers do is, they will halve the signal amplification and try to get this ECG complex into the paper. But you need to detect and correctly interpret the ECG. So please pay attention to the paper speed and the signal amplification. Now, what do you think about this ECG? This is actually, now this ECG has 3 ECG rows, but all 4 rows are printed at the same time, same lead. So if you look at from top to bottom, you can see the same ECG complex or the same depolarization in 3 different leads. You can see the same depolarization in L1, L2, L3, and L2 again. 4 complexes. So the L2 in the second row and the L2 in the 4th row are compatible. So how can you have the same heartbeat having an arrhythmia and a normal beat at the middle? If you look at the 4th row, it is all normal. What actually has happened is that this patient has started moving. Maybe something like brushing teeth or something like that, moving or shivering or having a fit, and led to these artifacts in the ECG. So this is actually a patient referred to us during my training for ICD implantation without detecting that this is an artifact, because this looks like somewhat like Tosardi pointis or multifocal ventricular tachycardia. So reading ECGs, one function of ECG is to determine the heart rate. Of course, if you want to know the heart rate, you can check the pulse, you can keep the stethoscope on the precordium and count the heartbeats. But sometimes it's difficult, and it is important to know the accurate heart rate for management decisions, for like increasing the heart rate control medications or adding some medication, because obese patients, and sometimes we can't. And especially people who are having atrial fibrillation, we might not be able to count the heart rate accurately. So doing an ECG is important. So if the patient is in sinus rhythm and regular heart rhythm, this is the way that we determine the heart rate. You count the large squares, number of large squares within an RR interval, and divide by divide 300 from that number. So in this, you can see within the RR interval, there are about slightly less than 4 large squares, more than 3 large squares, and less than 4 large squares, if you look at this. So if it is 4 large squares, 300 divided by 4 is 75. If it is 3 large squares, 300 divided by 3 is 100. So the heart rate of this patient is between 75 and 100. I would say it is close to 80. So you can get a rough estimate of heart rate by looking at the ECG. So please know how to determine the heart rate by looking at the ECG. So first we'll discuss the ECGs with sinus rhythm. Sinus rhythm means there is a P wave, and the P wave is always followed by QRS complexes. Now you may wonder why we often use L2 as the rhythm string, because the P wave is best seen in L2 as well as in V1. So in order to determine the rhythm, the most important way to know is the P wave and the relationship of QRS complex to this P wave. That is why we normally take L2 as the rhythm string. So this is an ECG of normal sinus rhythm. Look at this ECG. This is a common ECG that we find especially among the adolescents and the young adults. This is called sinus arrhythmia. If you look at the middle part of the ECG, the heart rate is faster than the sides of the ECG. So at the beginning of the ECG, the heart rate is about 50, and towards the middle, it becomes faster than 75 even. So this is a classical example of the heart rate variation during expiration and inspiration. So during inspiration, heart rate gets faster, and expiration, heart rate gets slower. So as a result, you know, even if you feel pulses, you will feel an irregular rhythm. But if you do a ECG, there are the P waves and followed by QRS complexes, and the patient is in sinus rhythm, although there is the irregularity. It is called sinus arrhythmia, a completely physiological phenomenon. Now this is again sinus rhythm, but slow heart rate. If you look at the upper panel, the heart rate is the number of large squares is almost like 9 large squares. So 300 divided by 9. The one below is almost 8 or little more than 8. So the patients are in sinus bradycardia. Sinus rhythm, no other arrhythmia, but slower heart rate. Bradycardia is heart rate less than 60 actually. So this is sinus bradycardia. So you need to know the causes of sinus bradycardia. There are extrinsic causes and intrinsic causes or cardiac causes. Extrinsic causes include hypothermia, and it's very uncommon in our setting. Hypothyroidism, obstructive jaundice, raised intracranial pressure, and the commonest cause of sinus bradycardia is being on heart rate control medication. So often, as soon as we see sinus bradycardia, we check the drug list and find beta blockers, non-dihydropyridine type calcium channel blockers, verapamil and diltiazem, digoxin and ivermectin, and so on. And we stop them, the heart rate becomes normalized. Neurocardiogenic syncope, carotid sinus syncope, or carotid sinus syndrome. The intrinsic causes include sick sinus syndrome, there's chronic degeneration of the SA node, and also infarction of the SA node in a right coronary artery territory infarction, especially common during inferior infarctions. This is sinus tachycardia, the opposite of sinus bradycardia, where you get the sinus rhythm, but the heart rate is faster than 100. In this patient, the last squares between RR interval is about 2.5. So you divide 300 by 2.5 and find that heart rate is between 100 and 150. So normal sinus rhythm, but the heart is faster than 100. Need to know the causes also. Again, there are acute causes like in anxiety, panic attacks, during pain, fever, sepsis, acute LVF, pulmonary embolism, and hypovolemia. The chronic causes for sinus tachycardia include chronic anxiety syndromes, stress, pregnancy, anemia, thyrotoxicosis, and catecholamine excess. Now, this is a ECG of ventricular hypertrophy. You need to know how to identify ventricular hypertrophy. It is usually identified by looking at the lateral leads. You see a tall R waves in V5 and V6, as well as taller R waves in L1 and AVL, and also deep S waves in V1 and V2. So there are several criteria. There are two types of criteria actually. One is called the electrical criteria, that is the heights and the depths of the R waves and S waves. The other set of criteria are called the left ventricular strain pattern, as indicated by ST depression. Right? So in order to diagnose left ventricular hypertrophy, both these sets of criteria should be there. Now, the electrical criteria include either the R wave in V1 and R wave in V5 and V6 more than 27 millimeters, or 27 small squares. And there is one criteria. The other criteria is when you add the S wave, the millimeters of S wave in V1 and V2, V1 or V2, to the R wave of V5 or V6, whichever the tallest, should be more than 35. So S wave in V1 plus R wave in V5 or V6. More than 35, that's another criteria. Or else, the R wave in AVL more than 12 millimeters is another criteria. So you have to have at least one of these criteria together with repolarization criteria or the left ventricular strain pattern. Because you can find a young, thin person with the electrical criteria. Because if they are young or adolescent or young people, they are very healthy. Their electrical activity of the heart is very high. And also when they are thin, your ECG leads are just attached next to the heart, and they get very tall QRS complexes. But in order to diagnose LVH, they also have to have left ventricular strain pattern. Otherwise, it can be just increased electrical activity of the heart. Now, this is a ECG of a patient with left ventricular hypertrophy. You can see tall R waves in V5, V6, and also deep S waves in V1, V2, and he fulfills the electrical criteria, as well as you see the reverse tick pattern in V5, V6. That is the repolarization criteria of left ventricular strain pattern. So together with it, you can diagnose it with high specificity. Similarly, right ventricular hypertrophy is indicated as an R wave, or positive R wave in V1. You know that in a normal ECG, there is no R wave. it is mainly a negative QRS complex with S wave. Only few examples are there for a positive R wave in V1. And right ventricular hypertrophy is just one of them. And that is followed by, and that is accompanied with right ventricular strain pattern as indicated by ST depression. So if you look at the V1, you can see that positive R wave in V1 as well as the left ventricular strain. And in this ECG, you also see a tall P wave. If you look at the L2 and L3, and that is because of dilated right atrium. We also call it P pulmonale. So right ventricular hypertrophy and P pulmonale occur together in most cases. That's why in this ECG, you see two abnormalities. One is right ventricular hypertrophy, the other one is right atrial dilatation. Now this is ECG with right ventricular hypertrophy. You can see tall R waves, so positive R waves in V1, V2, and also right ventricular strain pattern, ST and T depression in V1 and V2. The other abnormality to know are the bundle branch blocks. Left bundle branch block or the complete left bundle branch block is identified as you can see in the picture. The His bundle is divided into a left bundle and the right bundle. When the left conduction along the left bundle branch is blocked, we call it left bundle branch block. It's indicated as wide QRS complexes and positive and sometimes bifid, or is slightly divided, slightly a small notch on the top of the QRS complex, and mainly seen in V5, V6, L1 and AVL, or the lateral leads. So that is how you identify complete left bundle branch block. It's the ECG with complete left bundle branch block. You can see wide QRS complexes with positive and slightly notched QRS complexes in V5 to V6, V5, V6, L1 and AVL. Similarly, this is a right bundle branch block that is indicated as widened and bifid QRS complex in positive QRS complex in V1. And this is another example of positive R wave in V1. And so this is the ECG. You can see wide and a bifid or notched and positive R wave in V1. This is as indicated as a complete right bundle branch block. Now, up to here, what we discussed was the sinus rhythm with sinus arrhythmia, sinus bradycardia, and sinus tachycardia, and also various small changes that you can detect in the ECG. But they are also important in diagnosis and management. Firstly, we discussed about the left ventricular hypertrophy and the right ventricular hypertrophy. Remember, in ECGs, you can't diagnose left ventricular dilatation and right ventricular dilatation. What you can diagnose is left ventricular hypertrophy and right ventricular hypertrophy. And also using ECGs, you can diagnose left atrial dilatation and right atrial dilatation. I showed you the changes in right atrial dilatation. We call it P pulmonale, tall tented P waves. But sometimes you also see widened bifid P waves. We call it P mitrale, and that is the abnormality you see in left atrial dilatation. So using ECG, you can detect atrial dilatation, but not atrial hypertrophy. We don't normally identify atrial hypertrophy. So you identify atrial dilatation. And by using ECGs, you can identify ventricular hypertrophy, but not ventricular dilatation. And then we also went on to the bundle branch blocks. I only showed you complete left bundle branch block and complete right bundle branch block. But if you have an interest, look for other bundle branch blocks. It can be fascicular blocks or trifascicular blocks or bifascicular blocks. And there are different bundle branch blocks you can identify by doing ECGs. They are also important. Next, we will move on to arrhythmias, starting with bradyarrhythmias. Right? They are abnormality of the cardiac rhythm. Right? Now, arrhythmias can occur without any symptom. Sometimes when we do ECGs for screening, you find that they are in some arrhythmia, like atrial fibrillation, that they don't know even. Never diagnosed, asymptomatic, they don't know. And some arrhythmias can straight away cause cardiac arrest and patients can die. So it's a wide spectrum of symptomatology, starting from completely asymptomatic status to sudden cardiac death. In between, you can have faintishness, lightheadedness, blackouts, chest tightness, shortness of breath, palpitations, anything. So if the heart rate is less than 60, you get bradyarrhythmias. Heart rate of more than 100, and arrhythmia, you call it tachyarrhythmias. Now this is a ECG. This is the importance of monitoring a ECG after ACS. You can see, if you look at the first couple of beats, they are normal sinus beats with ST elevation. So this patient was having a myocardial infarction. And suddenly, patient has gone into a ventricular tachycardia. And he will rapidly deteriorate into cardiac arrest if he continue to have this. So that is how the arrhythmias are started. That is why I want to show you this ECG. Normal sinus rhythm, within seconds or split of a second, it is a fatal arrhythmia. Now, I always say there are a few ECGs, maybe 7 or 8 ECGs that you must be able to diagnose. If you don't diagnose, the patient will die. So that is the core knowledge that you should have in ECG. Mandatory to know. So 4 ECGs are shown here. They are the ECGs of a cardiac arrest. If you develop these ECG patterns, the patient will have a cardiac arrest. So they include the ventricular fibrillation and the pulseless ventricular tachycardia, as well as asystole and the pulseless electrical activity. 2 of these are shockable rhythms. What are they? Ventricular fibrillation and pulseless ventricular tachycardia. So if you detect this rhythm correctly, then the treatment is, as soon as possible, you have to do cardiac fibrillation. You can do a defibrillation and revert the rhythm back to sinus rhythm. The other 2 rhythms, asystole, where there is no electrical activity coming along the conduction system. And the other one is pulseless electrical activity, where there is a ECG wave pattern, heart is generating electrical activity, but heart is not contracting. As a result, patient has arrested. So these ECGs are very important ECGs. Now this is one form of bradyarrhythmia where the heart has SA node has fired normally and suddenly it has stopped firing. So we call it synod node arrest or synod node pause. So if you look at this ECG for 3-4 seconds, heart is not beating at all. So during this time, patient can be symptomatic, patient can have a syncope, lightheadedness, a dizziness, or even a blackout and a fall. So what happens in elderly is they fall and break hips. And sometimes we diagnose these causes for the first time when they are brought to the emergency department for surgery. So this is sinus node arrest. Sinus node has stopped firing. And to complicate the matter, sometimes they have these causes and sometimes the heart is going very fast also. So they will either have sinus tachycardia or atrial fibrillation. And we are not in a position to give them rate control medication because at no time they also have bradycardias and sinus poses. So what we do is we implant a pacemaker and then start them on rate control medications. And the other place that can be dysfunctional is the AV node. Sick sinus syndrome from SA node and AV blocks. We also call them heart blocks, although I don't like the word. We also call them heart blocks. AV block is, anyway, at the AV node, there is a delay in the electrical conduction that is to protect the left ventricle from the atrial electrical activity. But this can get delayed, further delayed, and develop first degree AV block, second degree AV block, and third degree AV block. First degree AV block is usually benign, but if you detect second degree AV block and third degree AV block, that may be an indication for permanent pacemaker implantation. Now, this is second degree AV block. What happens here is every other P wave is conducted to the ventricles. If you look at this ECG, one P wave is not followed by QRS complex, and the other P wave, that P wave is not seen just after the T wave. Look at the small wave just after the T wave, that is the P wave is not conducted to the ventricles, and the next P wave is conducted. So this is 2-to-1 AV block. It's a complete AV block. There is no connection between atria and ventricles with regard to the electrical activity. Nothing of the electrical activity from the atria are coming to the ventricles. So this is a complete AV block. It's more serious situation, and he needs early pacemaker implantation. So as an intern officer, if you see a patient with bradycardia, there are few things that you can do. Right? And these are all mentioned in the survival guide that you are going to have from the Sri Lanka College of Internal Medicine as well. Within this year, you will be able to see that. Please find a copy, buy a copy, and keep that with you. All these emergencies, how you manage and in that situation is nicely detailed there. So in a bradycardia, firstly, you quickly look at the drug chart and see whether there are any medicines that further reduce the heart rate. So rate control medication should be found out and stopped. Electrolyte abnormality should be corrected. The hypokalemia, hypocalcemia, hypomagnesemia should be corrected. You can give some atropine, 0.3 milligrams to 0.6 milligrams you can give, or you can give even a higher dose up to 3 milligrams to keep the heart rate high. And also you can start isoprenaline infusions. You can give start isoprenaline infusions and try to maintain the heart rate at a reasonable level. Then you can do temporary pacing. Again, there are two types of temporary pacing: external pacing. If you have a defibrillator that has this external pacing facility, you can attach the leads on the chest and keep stimulating the heart until you find a more permanent way. Or else you can introduce an intravenous pacing catheter and start doing temporary pacing using that. Or else you can refer him for permanent pacemaker implantation. And this is about tachyarrhythmias. Tachyarrhythmias can be divided into two. One is called narrow complex tachyarrhythmias and wide complex tachyarrhythmias. Narrow complex tachyarrhythmias occur from the atrial side of the heart. So they are also called supraventricular tachyarrhythmias or narrow complex tachyarrhythmia, where the QRS complexes are narrow or normal width, but they have a tachyarrhythmia. That's why it's called narrow complex tachyarrhythmia. The opposite of it is wide complex tachyarrhythmia. So the QRS complexes are wider. Usually they are ventricular tachyarrhythmias, but sometimes even the supraventricular tachyarrhythmias with certain bundle branch blocks can cause wide complex tachyarrhythmias. So the common causes of atrial tachyarrhythmia are atrial fibrillation, atrial flutter, and atrial tachycardia. All arise from the atrial syncytium or the atrial musculature. And they share common etiologies that includes left or right atrial dilatation, chronic respiratory problems, alcohol, thyrotoxicosis, all are same. Now, this is ECG of atrial fibrillation, a very common arrhythmia, and you should be able to detect this. How you detect it? By identifying irregular QRS complexes. They're not only irregular in the rhythm, but also the height of the QRS complex is irregular. And if you look at the baseline, you can identify small fibrillatory waves. We also call them simple S waves. So this is atrial fibrillation, and you need to know how to manage this out of this topic. But it's either rate control strategy or the rhythm control strategy. You try to keep the heart rate controlled or try to revert the patient back to sinus rhythm. Both are same though, no mortality benefit over another one. And also you need to know how to look for the risk of thromboembolic complications by atrial fibrillation. So CHADS2 score is the one that we normally use and is detailed on the screen, and you should be able to calculate the CHADS2 score. If it is 0, there's no need of anticoagulation, no antiplatelet medications. If it is 1, we can give antiplatelet medications. If it is 2 or more, warfarin should be started. The rate control strategies can be by drugs like digoxin, beta blockers, non-dihydropyridine type calcium channel blockers, verapamil, diltiazem, or else you can, sometimes when we can't control the heart rate by giving medications, we just ablate, knock off the AV node and create a complete heart block in this patient. That will protect, because none of the electrical activity is coming to the ventricles from the atria. So you can protect the ventricles, but now the patient is in complete AV block. For that, you can put a pacemaker in. Rhythm control, there are medicines to control rhythm like amiodarone, sotalol or flecainide. But what is popular now is to do a catheter ablation of the atrial fibrillation. That is done by isolating the pulmonary veins. They have found that around the pulmonary veins, entry of the pulmonary veins only, it triggers the atrial fibrillation. So you isolate that area and burn out, and patients will not have atrial fibrillation afterwards. Anticoagulation, you can use aspirin or clopidogrel, antiplatelet medication. And the common one to use in the hospital is warfarin to maintain INR between 2 and 3. And the newer oral agents, so newer anticoagulants or direct anticoagulants include dabigatran, apixaban, and rivaroxaban. We have all these medicines in our country, but not available in the public sector. Now, this is ECG of atrial flutter, just like in atrial fibrillation, but the fibrillatory waves are small, therefore we call them simple F waves. The flutter waves are like sawtooth appearance. They're like sawtooth. And as you can see that, the upper panel is atrial flutter with 2 to 1 block. The lower panel is atrial flutter with a variable block. This is another ECG with 2 to 1 block. Atrial flutter. If you look at the baseline, you will identify the flutter waves. And the next one is the junctional tachycardia. So first we discussed about the atrial tachyarrhythmias, that includes atrial fibrillation, atrial flutter, and the atrial tachycardia. The next level is junctional tachycardia, or also called nodal tachycardia, because the arrhythmia starts at the node level. Here what happens is, in this picture, the upper one is normal, but if you look at the lower one, the first lower one, there's a there's a creation of a circuit. There are two pathways, faster pathway and a slower pathway. So when the electrical impulses go through the fast pathway, the electrical impulses from the slow pathway still come. Therefore, some of the electrical activity can go up along the slow pathway and create a electrical current at this place that will trigger off the junctional tachycardia. So two types of junctional tachycardia. One is called the AV-NRT type. The first picture here, where the fast and the slow pathways are within the node. So within the node, there are two pathways. So it is called AV-NRT. Other one is called AV-RT tachycardia, atrioventricular re-entry tachycardia. And the pathway is outside the AV node. There's a difference. But the treatment is same. So this is AV-NRT tachycardia. Heart rate is more than 200. That happens because these arrhythmias usually occur among young people. And with this heart rate, they are usually asymptomatic. They can be asymptomatic, but not very much. They can have a slight tightening of the chest and palpitations. This is AV-RT tachycardia. It is identified by looking at the QRS complex and what is there just after the QRS complex. If you look at L2 and L3, you can see that there's a T inversion that is actually the part of it is the P wave, inverted P wave. So AV-RT tachycardia is diagnosed, there is arrhythmia, there is regular, and also you can find inverted P waves after the QRS complex. This is how you manage nodal tachycardia. We can do vagal maneuvers like the carotid sinus massage or Valsalva maneuver. And the drugs, the pharmacotherapy includes adenosine. You need to know how to give adenosine because it has a half-life only few seconds. Therefore, you have to give it as a rapid push followed by a flush. So you can start with 6 milligrams, you can go up to 12 or even 18 milligrams. Usually, the patient reverts back to normal rhythm. The other choice is to give verapamil, 5 to 10 milligrams IV over 5 to 10 minutes. So 1 milligram per minute like dosage. WPW syndrome is also somewhat similar to a nodal tachycardia because this is also occur as a aberrant pathway with re-entry circuit. So how you identify it is if you look at even say V4 or V2, V3, the QRS complex starts soon after the P wave. There's hardly any PR interval here in this ECG. So soon after the P wave, the depolarization of the left ventricle starts. As a result, you initially see a bit awkward wave. We call it delta wave. So delta wave is a feature of WPW syndrome. Next, we go to one of the very important arrhythmias. It's a wide complex tachyarrhythmia called ventricular tachycardia. The importance of ventricular tachycardia is it can deteriorate into a cardiac arrest or ventricular fibrillation if not treated early. And the presentation with ventricular tachycardia could be varied. Some people can present with ventricular tachycardia, but they are minimally symptomatic. They have symptoms, but very minimal. They are hemodynamically stable. So you can use pharmacotherapy like IV amiodarone or IV lignocaine to revert this patient back to sinus rhythm. The same ECG, but the presentation may be vary in some other people, and they present with cardiogenic shock. Their blood pressures are very low, they are very symptomatic. And there you can't wait for the action of pharmacotherapy. So the treatment is giving DC cardioversion. Now you need to understand the difference between the defibrillation and DC cardioversion. DC cardioversion is done in people who have not arrested. They have a cardiac output, like this patient, although the patient is in cardiogenic shock, still in usual rhythm. So for them, we have to synchronize and give a cardiac shock. So that is why it is called synchronized cardiac version. But if the patient is arrested, heart has stopped, so you are desperate, you straight away give the maximum dose of maximum electrical current using the defibrillator. This is ECG of ventricular tachycardia. You can see wide QRS complexes. They are all pointing towards the same direction. And also, the book says, although they are rare, sometimes you can see fusion beats. That is, because there's no AV block. Electrical activity from atria also can come and merge with this QRS complex. So sometimes you can see fusion beats and sometimes you can see capture beats. There, the QRS, the sinus node wave predominates and form a normal QRS complex, almost normal QRS complex, in between the ventricular tachycardia waves. Now this is another ECG. It's also ventricular tachycardia. It's called multifocal ventricular tachycardia or Tosardi pointis. Treatment is same like in ventricular tachycardia, but also you need to quickly look for electrolyte abnormalities and treat them with calcium and magnesium and also sometimes potassium. So you can start giving IV magnesium sulfate as a treatment for Tosardi pointis, and also you need to identify the cause and try and reverse it. Now, before winding up with the white complex tachycardia, I want to show you this ECG because that is a common ECG again you might find in the ward. This ECG you can see after the thrombolysis. And it is called idioventricular rhythm. Now there are two types. One is the heart rate will be lower, like 40s or 50s. It's called idioventricular rhythm. And the other one is heart rate is faster. And white complex is called accelerated idioventricular rhythm. Both these rhythms are due to spontaneous electrical activity of the ventricle because the electrical activity has stopped coming from above. So the ventricles have taken over to stimulate the depolarization of ventricles. So this is idioventricular rhythm. Now you all need to identify ventricular fibrillation. Why I showed this, the person who took this ECG didn't know that the patient is in ventricular fibrillation. Otherwise you wouldn't have completed a 12-lead ECG. As soon as you see this rhythm, you have to stop it and start CPR, which has not happened in this case. Now going into ischemic changes, so ischemic heart disease. Firstly, you need to identify ST segment changes, like here, subtle ST depression, 1 to 2 millimeter ST depression, as you can find it non-STEMI or non-ST elevation acute coronary syndromes. Look at this ECG. You can see ST elevation in the lateral leads, starting from V1 to V4 and also V5, you can see very clear ST elevation. So identifying STEMI ECGs or ST elevation MI is another mandated thing. So I only told you few things. One is cardiac arrest ECGs, ST elevation MI ECGs, ventricular tachycardia ECG, and later on I'll show you hyperkalemia ECG. Those are the ones that you must know when you start your internship. Now this is ECG anterior STEMI, as you can see. Now extensive, anyone should be able to identify this ECG, very tall, like 25 millimeter ST elevation. ECG, and it spreads from V1 to V6, L1 and AVL, with reciprocal changes in the inferior leads, L2, L3 and AVL. So this is an extensive anterior infarction. Another ECG with anterior STEMI. Another ECG with anterior STEMI. See, if you look at L1 and AVL, forget about the rest of the ECG. If you get only this, you should be able to diagnose a STEMI. It's only 1 to 2 millimeter ST elevation. This is inferior STEMI. You can see the ST elevations are there in L2, L3 and AVL, and also reciprocal changes in AVL, inferior STEMI. Lastly, you also need to identify ECG abnormalities of electrolyte abnormalities. You can see how the ST segments change with varying levels of hypokalemia, either below normal or above normal. So upper panel is hypokalemia, and as long as or as far as the serum potassium reduces, the ECG becomes more and more abnormal, and you develop a long QT interval, and that is a risk of ventricular tachycardia from long QT interval. The below panel is hyperkalemia. What happens? Initially, it starts as tall tented P waves, and then the QRS complex get widened, and the P wave get inverted. And ultimately, when you have a higher potassium level, you will develop a sine wave like this, and next time you will go into asystole. Therefore, now ECG of hyperkalemia is also I classify as a mandatory one, because by looking at that, you should be able to suspect or diagnose hyperkalemia. And it's a medical emergency. You have to start treatment as early as possible. Now, this